I'm going to go ahead now and introduce you to Dr. Larry Page. He's a graduate of the University of Michigan School of Dentistry. After completing service in the Air Force, he completed a PhD in microbiology at the University of Maryland, and concurrently he completed a residence in oral and maxillofacial pathology at the University of Maryland School of Dentistry. While teaching oral pathology at the University of Kentucky College of Dentistry, he was offered the opportunity to take the periodontology residence while continuing to teach. He has been a tenured associate professor at both the University of Kentucky and the University of Maryland, and more recently has been a part-time clinical professor in the Department of Periodontology and Oral Implantology at Temple University, Kornberg School of Dentistry. Dr. Page has been a full-time periodontist in Columbia and Ellicott City, Maryland, for the last 41 years. So welcome, Dr. Page. I'm going to go ahead and turn this virtual podium over to you.
Thank you very much. And I thank you all for listening to me. And today we're going to be talking about periodontitis in a little different light than we learned in dental school. And this all arises from the fact that I didn't take my residence in periodontics until I already was a microbiologist and an oral pathologist. So I was well acquainted with infectious diseases and how they should be treated and monitored. And taking the residence in periodontology, I realized it was not really quite up to par with infectious disease control. And that got me started on looking at alternative ways of treating periodontitis, as we knew even at the time that this is an infectious disease. And so with that, we'll get started. First of all, I'm sure you all know that pathogenic periodontal microorganisms are locally destructive, and they do have severe life-shortening systemic disease potential. And neither non-surgical nor surgical conventional periodontal therapy can predictively prevent local growth or systemic spread of these pathogenic periodontal bacteria. And this was a very, very big problem for me as I went through the program. It was obvious. Using proven infectious disease control techniques, we can predictably prevent and stop periodontitis, as well as perioimplantitis. Both of these things are very similar in origin. We can also reduce or eliminate the incidence of systemic disease associated with these oral microorganisms, the pathogenic microorganisms. And there's no downside for us or for our patients. We can greatly improve treatment outcomes and satisfaction with practice, no question about it. And the answer of how do we do all this is because periodontitis and perioimplantitis and caries as well are chronic infectious diseases. And applying the methods of chronic infectious disease control techniques developed for medicine has been shown to be effective for periodontitis and caries as well. And these are the methods that have been developed and proven the most effective over the past 160 years of medical care. All physicians are required to use infectious disease control techniques. And at this time, they're beginning to expect us, the medical community is beginning to expect us to do the same. For example, here in the US, I don't know about elsewhere, but whenever a surgeon is going to do joint replacement or many other surgeries, they now send a clearance form to the local dentist. And then we're supposed to clear that patient for surgical procedures, whichever the procedure is, based on the fact that their oral infection status is suitable for the surgery. Well, the question comes in, how do we know that? We don't really know that if we're not going beyond what we were taught in dental school. So in summary, we need to know if and where pathogenic bacteria are present. And this is not just during, but after treatment. So applying infectious disease control techniques, we can prevent periodontal infections and we can treat them. So if you stop the causative agent, which is the infection, Even regrowth of alveolar bone is possible without surgical intervention, as you'll see in some of the later radiographs that we're going to show you. So course objectives, we're going to learn a little bit about microbial biofilms and how important they are for disease prevention and control. And we're going to learn a bit how microbial biofilms cause periodontitis as well as systemic diseases. We're also going to learn how to identify people who are highly susceptible to both periodontitis and peri-implantitis based on their infection levels. We're also going to learn how to identify the most disease-susceptible sites in an individual's mouth. Also very important, something that we weren't really taught in dental school, most of us. We're going to learn how to predictively prevent and stop periodontitis and peri-implantitis using the methods we're going to talk about. We're also going to learn how to accomplish disease control without causing toothbrush abrasion and recession. We were all taught to floss and brush and scrub teeth. You see it on TV even today, people scrubbing their teeth. Well, that's how recession is typically formed and how toothbrush abrasion is formed. So we're going to learn to prevent or reduce systemic infections caused by oral pathogenic bacteria. And that's something that we certainly weren't taught in dental school. Now, to understand all this, we need to talk a little bit about biofilms and what biofilms are and how they cause disease. Now, both periodontitis and peri-implantitis, as well as caries, even though we're not going to talk much about caries today, these are all microbial biofilm infections. So it's important to understand the nature of biofilms. And as you probably all know, their biofilms, microbial biofilms, are not just around our teeth, they're all over our body. Any exposed surface, outside and inside, is covered by microbial biofilms. And they're essential to our bodily functions. But when your immune system doesn't control their growth, we wind up with disease. So their influence can be beneficial or harmful depending on our body's defenses and the types of microorganisms present. So we're going to, of course, concentrate on the harmful effects of biofilm today, very little on the good effects, although we will mention them. So let's take an overview of what biofilms are. And biofilms are masses of bacteria, and they form at in the gingival margin situation. They form at the gingival margin within about 20 minutes after you do a cleaning. And all the bacteria present in that area are the ones that start forming this biofilm. And once they form, and they get out of control, especially, many physical and mental diseases are influenced, if not determined, by our microbial biofilms. And this includes oral microbial biofilms. So how do biofilms work? And it's basically the fact that bacteria and other microorganisms like growing in communities, just like we do. And communities offer many advantages compared to independent growth. And that is, once these bacteria are in a biofilm, in a community of bacteria, the genes of all the bacterial species are available to the biofilm. And different bacteria are actually directed to express genes according to the needs of the biofilm. And it's interesting, back in school when you had microbiology, I'm sure you all looked at plates and agar plates, and you saw these wonderful shapes of colonies, the geometric patterns. I always wondered what that was, why that was happening. Even when I was in microbiology, I didn't quite understand it. I think I do now, and that is the bacteria in the biofilm. In this case, it's a single species biofilm. Each bacteria in different areas is signaled to do different functions depending on the needs of the whole biofilm. So you wind up with these beautiful patterns. One of the questions comes up, which of the bacteria direct the biofilm to do these various things? And the answer is, nobody really knows this. So we'll not talk too much about that yet. A little bit is known about the fact that there are short communication molecules, but other than that, we don't know which bacteria are assigned the actual directive functions. Now, the primary function of a biofilm are both reproduction and nutrition, as primary function of all living organisms. And as biofilms grow, the nutrition needs increase. And that's important for us too in treating periodontitis. Microorganisms grow in the biofilm by a process called microbial succession. And this is not new to you. Most of you have had information on what is microbial succession, but we will review it today a bit. And we'll use the gingival marginal biofilm and sulcular biofilm developments to describe microbial succession. And basically what it means is biofilms grow in steps, beginning with the initial available microorganisms. And just as in embryology, each step in the sequence sets up the environment for the next step. And along the way, as you go from low pathogenic to high pathogenic, your body's defenses, ability to stop this succession, is what determines whether you're going to have periodontitis, whether you're going to have severe periodontitis, or somewhere in between. First of all, as I mentioned before, if you clean and disinfect and get rid of most of the bacteria, the pellicle will form very, very quickly. Within minutes, it starts forming. And the first bacterial biofilm will begin growing in about 20 minutes. Once the biofilm begins forming, the bacteria coordinate their growth and function using signal molecules, as we mentioned before. And each organism within the biofilm, depending on its distance from the center or whatever that center of the biofilm is directed to use specific genes for the overall benefit of the biofilm. When the biofilm develops, it also develops an outer protective layer, which means it's somewhat protected by many of the solutions that we're telling people to rinse with. Now, the biofilm starts at the gum line, and it grows in every direction it can. Above the gums, the biofilm grows, especially between the teeth in a protected area. The biofilm will basically eat food and other salivary materials that it can get a hold of. And also, as the biofilm grows in between the teeth, above the gums, in the contact area, it will try to excavate organic material from the tooth itself. And if there's sugar available, it produces acid. And this is what dental caries is. So the biofilm above the gums, that type of environment selects for the specific bacteria, strep mutans and others, that will be able to help the biofilm grow in that environment. Below the gingival margin, there is a different situation. And these are bacteria that will eat basically tissue fluids and tissue. And we'll get into that in a few minutes. First of all, let me talk a little bit about why is there a sulcus. This is one of the things that I never knew in dental school, where it's shown there is a sulcus and it goes around each tooth, and that's all we really knew. And we could tell what it was from the microscopic sections that we saw in gross anatomy and such. But why is it there? And this brings us to a point of, I'm going to go through a brief review of everything we're going to talk about today. And this is what I tell to patients when they come in the office. Of course, when a patient first comes in the office, you greet them, and it's very important to sit and listen to what they have to say. And often when people come into my office, they'll tell me, well, they went to another periodontist and they were told they have these things called gum pockets and they have to cut them away, or nowadays they have to use lasers to reattach the gums, and it's going to cost a lot of money. And they have friends that went through this and they had to have it done again a few years later. And is there any other way? Well, it's a very interesting situation. That's basically what we were taught in dental school. and in the residency programs. But that's not really quite the information. When you think about it, gum pockets, periodontal pockets, are the result of the infection. They are not the cause of the disease. And if you're not going to control the infection, you're just going to be spinning your wheels. And that's in fact what happens. And that's why people have repeated surgical procedures. I may be overstating it a little bit, but not much. So what I do is when people come in the office, I give them a simple explanation, which is about 5 minutes. And I'll do that for you right now. And it goes through everything we're talking about. And we start out by saying that teeth are hard but very brittle. The only way our body can make a structure as hard as a tooth is basically by lining up atoms in a straight column and forming a crystal. And that's fine, except when crystals meet a surface, there's always a tendency for clefts to occur between these columns of atoms. And that's how you shape diamonds as well. But that's why we get tooth fracture. And of course, these fractures happen when there's sudden impacts. So what this means is that there's a shock absorber between the tooth and the jawbone, which we call, of course, the periodontal ligament. And I tell them that in this space, and I have a diagram, which I will show you later, in that space between the bone and the tooth, the bone and the teeth are connected by collagen fibers. And collagen fibers are slightly elastic. And there's also fluid in there. So when you're chewing, the tooth moves up and down and side to side. And that protects you from sudden impacts that can break your teeth. Now, there's a problem. When that tooth emerges from the tissue, it has to be sealed off from the outside world. And initially, when teeth first evolved, there was a flat layer of gum that just covered the top of the bone. There was no sulcus. The flat layer of gum went directly to the tooth and attached at 90 degrees. And of course, when the tooth moves sideways, that stretches along with the tooth. Now, unfortunately, collagen fibers have a very limited amount of elasticity. So in that early system, what happens is many of these fibers are constantly being overstretched and broken, which means you have constant repair and a lot of energy use by these early animals. And anything that uses too much energy is a problem in a biological system. So over time, what happened is tissue evolved and built up behind that flat layer of gum, which eventually evolved. So now that flat perpendicular layer is now parallel to the tooth, forming the sulcus. Now when the tooth moves sideways, the whole unit of tissue can move with it without tearing the collagen fibers. And that's basically why we have a sulcus. And it's part of the shock absorber, and it works very well. Now, it's also a wonderful place for bacteria to grow. Now, bacteria start at the gum line, and if you cleaned and disinfected, as I told you before, it takes about 20 minutes for a biofilm to be forming at the gum line. Bacteria like growing in communities. The biofilm forms at the gum line, and after an hour or two, you can actually scrape with your fingernail and a toothpick, and you come up with a white sticky material. That's the bacterial biofilm. Now, in the biofilm, these bacteria are communicating with each other, and they set up an organization pattern where each bacterial type is responsible for doing certain things for the benefit of the whole biofilm. And it starts growing above the gums, as we talked before. And the bacterial biofilm begins growing into the sulcus. As soon as the bacteria grow into the sulcus, these early bacteria, and we were told in dental school that these bacteria are not pathogenic. Well, that's not quite true. The early bacterial biofilm starts producing enzymes that break down the inside lining of the gingival sulcus. So you get bleeding and tissue exudate coming into the sulcus, which feeds the biofilm. Our body also produces an exudate that comes in with various chemicals to try to fight the bacterial growth. Now, the tissue responds to this insult, to this ulceration, with inflammation. The gums get puffy and red. And this is what is gingivitis, of course. Now, the early microbial biofilm under the gums, these bacteria are reproducing. They're eating, they're excreting, they're using up oxygen. They change that environment rather rapidly. And after a short period of time, probably less than a day, they start changing the environment enough so more aggressive bacteria can start growing into the biofilm. And the question is, where do these bacteria come from? Well, they come from within our body. And this is something we'll get into later, by the way. But these bacteria that invade our body, often bacteria, will set up reserve components, small microbial biofilms that don't reproduce unless they're stimulated by inflammation. We'll get into that later. But anyway, so the more aggressive bacteria start growing into the biofilm, and once they're established, some of them begin leaving and invading the surrounding tissue. Now remember that the function of the biofilm is to increase nutrition, and that's exactly what's happening with the invasion of the tissue. Up to now, the biofilm is dependent on the tissue fluid and blood that results from epithelial ulceration. Now we have bacterial invasion where bacteria actually are within the tissue above the alveolar bone. They're in the tissue and they're basically eating us, and they're causing destruction. And this releases more nutrition for the biofilm, which is now extending its tentacles, of course, into the tissue. Now, these bacteria in the tissue now have access to your entire body. And here's where the increased risk of strokes and heart attacks and Alzheimer's and such occur. So at this point, what I tell patients is our job is to train you to disrupt and destroy this biofilm on a daily basis. And even in deep pockets, you can get in and do this. Basically, floss does not work very well, and it causes actually more damage than good, and most people don't floss. But there are techniques where you can learn to get into these even deep pockets and disrupt the biofilm and flush it out with a irrigator. We use a chlorine solution. Many of you have heard of Jorgen Slotz at USC, and he's more recently demonstrated this in several papers. Very, very effective antiseptic. Chlorine bleach solutions are the most effective antiseptic we know of. That's why they're used in water control and in swimming pools. It's the reason that your drinking water in most areas is treated with chlorine bleach in order to prevent cholera and other such diseases. Well, and it's also very inexpensive. So we use about a half a teaspoon of chlorine bleach, and we'll go into this later as well. Half a teaspoon in a quart of warm water. At this point, I tell patients that we're going to go back and take a sample from under your gums and see what's growing. So we'll go back into a clinical room. I will show them what a sulcus looks like with a mirror. I'll show them going in between the teeth with a small tufted brush or a Proxa brush and remove a biofilm, put it on a microscope slide, and come back with a phase contrast microscope and show them what's growing. And it's usually very, very moving for them to see actually these bacteria that we're worried about. Now, once the more aggressive bacteria begin growing into the biofilm, the diagram on the right shows what happens. The biofilm begins breaking the collagen fibers away from the tooth, so the trench gets deeper and deeper. The sulcus becomes a pocket. And in the tissue, inflammation has many functions, one of which is it makes local bone get taken away. Basically, it stops osteoblastic activity while the osteoclastic activity continues. So the bone is taken away as a defensive measure. This is a supporting bone for the tooth. And now we have periodontitis. Now, everything we've talked about up to now is basically what we're going to talk about the whole rest of the course in slightly more detail than we're talking about. than we have talking about. But it's important, very important for the patient to understand what's going on and what you're going to try to do. And treatment in my office is based on training people to control these infections. Then we do a scaling root planing, and then we wait a week or two so that if they're missing anything, even in the deep pockets, it'll be time for the microbial succession to occur and more aggressive bacteria to grow. That's when I evaluate, and I take samples from all the hard to get at areas and look under the microscope with the patient. If there are problem spots, they go back and we work with their training techniques and resample it at a later date. And every time they come in for a periodontal maintenance appointment, we take samples from all areas and look under the microscope. It's very quick, very inexpensive. It's probably cost us about a quarter for each sample, or 2 samples, you might say. Okay, back to microbial succession. As I said, in the sulcus, the initial organisms produce the enzymes that disrupt sulcular epithelium, which allows tissue fluids and blood into the sulcus, which feeds the biofilm. And our bodies produce exudate with factors to try to control the biofilm succession. And of course, the biofilm continues to want more and more nutrition. In a closed site such as a sulcus, biofilms grow rapidly and they change the environment in the sulcus and within the biofilm itself, of course. Inflammation is initiated, as we discussed, and white blood cells migrate into the site in an attempt to control succession, and that's gingivitis up to that point. And quick aside about gingivitis, again, we discussed it before. Whenever you have inflammation, long-term chronic inflammation is going to cause local bone resorption. So the old idea about gingivitis doesn't cause bone loss, I'm not so sure that's true. I think it's the other way around. Chronic inflammation is going to cause osteoblastic inhibition. So inflammation tries to prevent infection from reaching bone by causing bone resorption. Of course, bone infections are very difficult to control, and that's probably why our body is doing this, is removing the bone. Gingivitis will cause bone loss, I believe. Now, alveolar bone loss can also be from inflammation due to trauma. And when I say that, I'm talking about traumatic techniques such as flossing and brushing, interdental brushing, and even regular tooth brushing. And perhaps even some of the disease that we pretty commonly see, like erosive lichen planus, is probably causing some degree of bone loss because you have inflammation associated with them. So back to succession. As the environment has changed, different organisms are better able to thrive than the earlier organisms, and we alluded to this before. Pathogenic microorganisms make more nutrients available to the biofilm by destroying tissue. And these organisms are the most desirable ones for the biofilm because they increase nutrition, available nutrition. Host defenses determine how far a biofilm can exploit the host. Now, there's a big spectrum to microbial succession in our gingival sulcus and periodontal pockets. If the host defenses are significantly compromised, we get worse disease. And it can get up to the point, especially in nutritionally deprived populations, where children can die of this, and adults too. So there's a little graph that I put together here. Host defenses on the bottom, at the lower left, very good, and it becomes less adequate as you go to the right. Pathogenicity increases from the bottom to the top as we go from left to right. And you notice gingivitis can be at that lower level when your defenses are fairly good, and maybe it never gets quite beyond that. You can get slowly progressive periodontitis. Now we'll talk about cyclic nature of periodontitis in a little while. But as as your immune system goes up and down over our life, and it certainly does, and at very short intervals. For example, if you're in college and you have finals, your immune system's probably going to be a little less effective than it was before. And in fact, that's where this ANUG at the top right occurs. Sometimes if your immune system goes way down under a lot of stress, the microorganisms are able to succeed to a further extent and cause a lot more damage. Instead of just local invasion, they can also cause a great deal of massive destruction. Noma, which you were exposed to, I'm sure, in pathology, that's when this ANUG gets out of control, and these are people with very low immune ability, and you start getting tissue necrosis of the cheek and the lips, and then these people die if they're not adequately treated. So even though we usually deal with the left part of this diagram, there is the potential for these organisms to cause local problems that can be quite severe. Now, bottom line is, the earlier in microbial succession in the sequence, the earlier we stop it or prevent it from going further, the less disease activity there's going to be. Now, most people are susceptible to periodontal destruction. More than half the population, in essence. Host defenses can't stop succession before aggressive pathogenic bacteria colonize, at some times at least. This transition to destructive periodontitis and peri-implantitis we'll go into some of the more important details that you probably have had some exposure to in dental school. Fusobacterium nucleatum is one of the transitional bacteria, thought to be, and it is when the first biofilm forms and you have relatively low pathogenic microorganisms. This is the bacteria that's known as a sticky bacteria. It starts growing in large numbers, and it allows the adherence of more aggressive bacteria to the biofilm. So it's always been considered to be a transitional bacteria, and an important one for that. Whenever you see it or find it, it can be a problem. It also has been implicated in causing at least one form of colon cancer. We're going to go back to that question that I brought up before, that statement, when I said that, where do these aggressive bacteria come from? What's going on? Why do we suddenly get aggressive bacteria that were not present in the mouth, and suddenly that they're there? This was a question that always popped up in residence and probably in dental school. Many people thought of it, but may have been afraid to ask. Do you get them from the environment, or from girlfriend or boyfriend or whatever? And the answer is, many bacteria have different ways of invading tissues. There's two kinds of systemic invasion. One is these bacteria are directly able to invade and use tissue. And that is what they do. That's a typical invasion when you have a bacterial disease. And they're eating us, basically. Also, some of these bacteria, if they can, the individual bacteria go out and find a spot in your body where there may not be much blood supply, and they form a small nidus of bacteria, maybe just a handful of bacteria that no longer multiply. So they're basically hiding from our immune system. And these are reservoirs. We'll call them microbial films, and that's really what they are. And they're partially or fully protected from our immune system. It could be arterial plaques, dense tissue, and any place there's low vascularity, these satellite biofilms may grow. And This is something that has not been well defined yet in the literature, but it seems to be that this is obviously the explanation for much of what happens, not just in gum disease, but in other diseases. And these satellite biofilms make chronic bacterial diseases very difficult to eliminate because you can treat them with antibiotics, but once the antibiotics stop, then these little hiding places, these bacteria that weren't affected by the antibiotics because they weren't metabolizing very much, they start growing and producing more organisms to recolonize the entire body. Now, Lyme disease is an obvious example of this. Tuberculosis as well, where if you Lyme disease, you get bitten by a tick, and you see that target lesion. If you treat it with antibiotics right away, it goes away, and you basically are cured. However, if you wait any period of time and you don't realize what's going on, then you may wind up with long-term antibiotic therapy, high doses, intravenous, and that may not even take care of the whole problem. So Lyme disease, tuberculosis, gum disease, these are all diseases that seem to have a reservoir in our body. And these are, we'll call them satellite biofilms. And they're likely inert until they detect chemical signs such as inflammation to activate and make some more bacteria. So these bacteria, by the way, you've heard the term planktonic bacteria. These are bacteria that are floating around and not yet part of a new biofilm or an old biofilm. And these are what these microbiofilms, satellite microbiofilms, will produce. So back to microbial succession itself. Once a pathogenic species grows, it accesses a biofilm, an oral biofilm, let's say in a periodontal pocket, it grows, and it achieves large enough numbers inside the biofilm, and then its internal signal, which is called quorum sensing, turns off the reproduction and activates the genes for invasion instead of reproduction. And that's, you've heard the term quorum sensing. That'll become more common in the literature and so on. But that's all it means. It's a change of patterns for a particular bacteria in a biofilm. Those planktonic bacteria that are now coming out of the biofilm invade, and that's what we talked about before. And then they can spread systemically. Now, in a periodontal pocket, or even in a sulcus initially, the most effective destructive microorganisms are the ones that become predominant because they provide more nutrition for the biofilm. So, and the most important, when we're looking at patients, their immune system, their defenses overall determine how much succession there is, how far the succession goes, and how much disease activity there's going to be. Now, this is that horrible diagram that we were all probably exposed to, which, of course, at the bottom you have the pellicle, and there's the biofilm growing above it, which this, of course, means very little. I'm not worried about you learning the names of all the bacteria. It's really not critical. And this will change over time, which becomes more important. It's the concept of biofilm succession and the concept of interfering with it that we need to keep in mind when we're trying to prevent or trying to treat periodontitis or periimplantitis. Using microbial analysis in the future, we should be able to correlate specific host defense defects by identifying the kinds of bacteria that are present. And that's probably become obvious to you over time, but anyway, that is true. So by identifying which pathogenic organisms predominate, we can determine the rate of future destruction in that person. If they have very high risk microorganisms, they're likely to have a much more aggressive kind of disease. That's pretty straightforward. So a less effective, less aggressive disease, you wind up with usually the less aggressive kinds of bacteria, orange complex rather than red complex microorganisms. Now, one of the things that has not been pushed on us by our education is the idea of substitution, microbial substitution. In a biofilm, each eco-niche can be filled by whatever is the most capable organism in the present flora to fill that gap. So common pathogenic bacteria that we're used to in treating periodontitis may be substituted with infrequent bacteria such as gut flora. If you live in an area that doesn't have good sanitary conditions, GI bacteria can replace the usual periodontal pathogens, producing a fecal odor. And you've probably smelled this in some patient. If they come in with that, they have a different kind of microflora than the ordinary patient that you may have. And they have to, if you're using antibiotics, which you may need to use, this is a different kind of flora that must be addressed. It may not be suitable to use the same, let's say, metronidazole or other things that are pretty typical for common periodontitis. You may have to use another antibiotic. Biofilms are very delicately balanced, not balanced, sorry about that, I'll have to change that, ecosystems. And that's important clinically, because if you break up these biofilms, it really wreaks havoc with the organisms within the biofilm. So if you're in there breaking up a biofilm or hitting it with a antiseptic that's very effective, critical non-pathogenic bacteria that are critical for that biofilm. In other words, not pathogenic bacteria may not be critical to establish the biofilm environment. Maybe there's other non-pathogenic organisms that are doing that. But if you hit those, the whole biofilm collapses, and those aggressive bacteria can be destroyed as well. And this is why sometimes antibiotics that shouldn't be able to control the pathogens, that maybe the pathogens are not susceptible to that antibiotic, maybe that bacteria, the bacterial biofilm has been destroyed, and that, although you haven't directly affected that bacteria, it's destroyed because its whole home is destroyed. It's still always best when you're using antibiotics, if you have to target the pathogenic bacteria. So that brings up some clinical questions. I know this is, I want to tell you that I understand that looking at gum disease as an infectious disease is a little different than we've been taught. I know we were taught more as a mechanical type of treatment of gum disease. If a pocket is more than 5 millimeters, you have to cut it away and blah, blah, blah. And unfortunately, that doesn't work very well. We'll go into that in more detail in a few minutes. But keep in mind that it is an infectious disease, and these infections can cause local infections. And as we'll get into in a little while, even Alzheimer's and other diseases may be affected by these oral bacteria that we're talking about. So it's not a minor problem. Gum disease is not a minor problem. And when you think about loss of tooth, people who have lost their teeth and have dentures have a lower, shorter lifespan than people who have not lost their teeth. Okay. One of the critical questions we have to ask for treatment: does the deep pocket biofilm depend upon the marginal and shallow biofilm? Well, this is important. Of course, what if you don't get all the bacterial biofilm at the base of that periodontal pocket? Well, it turns out that if you look at this diagram, you'll see that the shallow biofilm creates a low oxygen environment and a lot of nutrients above the deep biofilm. And yes, the lower biofilm, the deep biofilm, does have some dependence on the upper biofilm, and it prevents the superficial, the upper biofilm, the sulcular, you might say the marginal and somewhat sulcular or pocket early pocket biofilm, the first 2 or 3 or 4 millimeters, prevents superficial host tissue from healing, which would isolate the deep bacterial flora and allow you to destroy it. Now, this is less of a factor if there's extensive lateral and furcation destruction. So this is probably true in many situations, but you always have to test it. Now, we can usually eliminate 7 or 8 millimeter deep biofilm with sonic brushing and high pressure irrigation with sodium hypochlorite, as we said before, half a teaspoon of chlorine bleach in a quart of warm water. And occasionally you'll find somebody that doesn't want this. Is swimming pool level of bleach. They don't want to use it no matter what. There is an iodine solution, molecular iodine solution produced by IoTech, which, and by the way, I have no association with any of the companies or products that I'm talking about today. No, I don't get money from them. So, but IoTech is a molecular iodine, which is very effective. Maybe not as good as hypochlorite, but it's effective and can be used as a substitute for sodium hypochlorite. So, if a biofilm is not controlled, patient should use a deep subgingival brushing technique, which we'll get into detail later, followed by irrigation with a hypochlorite at high pressure. And this is a proxa brush accessing into a deep pocket. And Dr. Tom Rams and I have published a paper on this, and we can pretty well destroy a biofilm to 12 millimeters of depth. And patients can use this. So it is effective, followed by the biofilms. Of course, your question always comes up, what if somebody doesn't want to do this? Well, you may have to do other things then. But we certainly have the technology to help patients in most situations. Now, the one thing you need to do when you have a questionable site, you must test it with microbial sampling. There's no other way to know whether it's controlled or not controlled, whether that patient is controlling this site or not. You cannot just look at it and say, this looks bad or good. It's not good enough. So now we're going to get into the details of biofilms' influence, certainly our metabolism. And one of the things that is a little surprising to most people is our brain function. Well, our brain function can be influenced by microorganisms. And it's these are biofilms all over our body, of course. It may not just be oral, but the oral biofilms may have seem to have an effect too, as we'll see. Biofilms, of course, as we describe them, I told you I didn't know what determines which organisms become the controlling organisms, and not very much is known about them. There's on microbial communication within the biofilm, there's a really good group of presentations by a molecular biologist up at Princeton. Bonnie Bassler is her name. You might want to get on if you want more information about this. And by the way, I have I think I gave to Dr. My brain is gone. I think I gave with this program, I gave a biography, a selected biography of papers if you're interested in them, and that should be downloadable soon. Biofilms can change us. Biofilms can signal our bodies to change our metabolism and control our defenses to allow them to better access our tissue. So these signals produced within the biofilm, these bacterial biofilms can actually send these signals to us, and our bodies can send signals back to them. And we don't know much about this at all, other than it seems to happen. Now, I'll give you an example, a good example, of how microorganisms can affect our brains. There's an organism called Toxoplasma gondii, which is a mouse and cat organism, but it can affect people too. And it causes a disease called toxoplasmosis. The organism infects the cat, and it is defecate. The cat defecates, and the mouse eats the feces, and is infected. The organism goes to the amygdala of the mouse in the brain, which changes the behavior of the rodent. The mice lose their fear of cats, and they're attracted to it. Actually, they become attracted to cat odors, and they're the ones that get eaten, and that completes the life cycle of this microorganism. And it's interesting, as you can see, these organisms are using their hosts just as mechanisms. They don't care about us, of course. They're just using us as mechanisms for their own survival. Infected humans, in pregnant women, there's a real problem. It can cause problems with the fetus, and it can also cause spontaneous abortion. But people also seem to have a reduced fear effect. So, and the other thing is, one of the things that's been found, an interesting finding, is antibody to toxoplasma is correlated to schizophrenia. So there's all kinds of interactions here that aren't really understood yet. Now, as I said before, we signal back to the biofilms, and the question is how much good that does, and probably does some good, or we wouldn't be doing it. But none of the details of this are well understood. Now, the biome, the term biome, this is a newish term, and it's the relationship, the intimate relationship between us and our biofilms. And we can't survive without our biofilm. And it's there's more microbial cells on in us than we have actual human cells. So why do we need to modify conventional periodontal practices? Well, what I've talked about so far is leading up to this, and we'll just summarize them with a few statements. Conventional treatment is unable to predictively stop aggressive periodontitis because it focuses on pocket depths and clinical signs that are the effects, not the cause of the disease. Refractory and aggressive periodontitis occur in conventional treatment. They do not occur when you're treating these diseases as infectious diseases properly. When you're identifying the microorganisms and targeting them rather than just the inflammation signs or the pocket depth. Conventional diagnosis is unable to control moderate risk disease when host defenses temporarily allow high risk infections. In other words, when your body's resistance goes down and you suddenly have destruction that you didn't have before, and then it may go down to a more quiescent level after that, how do you detect that? You can't detect it with conventional methods unless you're looking at the microorganisms. Then you can detect it and work to treat it. Pockets are the result of previous disease, and they are not diagnostic for present disease activity in any way. I shouldn't say in any way, but they're not reliable at all. Clinical signs of inflammation have been proven unreliable as well. Active disease can be present without bleeding, and a low pathogenic biofilm can cause bleeding. The solution is disease activity cannot occur without causative microorganisms. That's the only thing. You can have deep pockets, and we do leave deep pockets. I don't care about the pocket depth as long as there's not an active high-risk infection. Patients can be trained to control high-risk infection even in deep periodontal pockets. And we can monitor each individual site for infection. That's one of the solutions. And that you can't do without an adequate plan for treatment. And it's got to be focusing on the microorganisms, not on periodontal pockets. And that's not to say you shouldn't watch periodontal pockets and test them, but that's not your primary focus. First of all, explaining periodontitis to patients, I've already done that with you. And patient cooperation, and staff. Your staff has to understand what's going on too and what you're doing. Now, here is an explanation that I put together. You can look at this by yourself later on. I've already gone through this earlier on in our presentation today. So, using diagrams, using models, you saw the wooden model I had in the last slide. I made that because there was nothing that was adequate that I wanted to use. Diagrams, these are very important, explaining disease to your patient. And as I mentioned to you before, one of the big comments I have when people come in, they were told they have these things called pockets and they have to be cut away or eliminated. Patient didn't understand anything. All they understand is a lot of pain, and they've heard people that had it done and had to have it done again, and they really don't want to go through that. Periodontitis, a little different in some ways. Now, if you look at an implant, this is the typical diagram you get from the producers of the implants. And this is not really what happens, because as you know, the diameter of the implant is less than the diameter of the original tooth. So what you wind up with is a smaller implant and usually a mushroom-shaped crown coming away, which overlaps some of the gingiva, which means you can't get direct access to the sulcus that forms next to the implant. And this is critical. People are told, use dental floss and go back and forth and side to side, and that just cuts gum and causes inflammation and can make it easier for microorganisms to grow. Here, the best general approach is high-powered irrigation with the hypochlorite solution that we discussed before. So, using infectious disease control protocol, we can radically improve the results of standard periodontal therapy. And that is a critical statement. There's no use cutting gum pockets away if you're going to let the bacterial biofilm reform. It's no use reestablishing connections between the tissue and the tooth if you're going to allow microbial biofilms to become pathogenic and form at the margin of this new attachment site. So we'll go over some questions right now, some comments. Does controlling periodontal infections work? And this is a series that Dr. Tom Rams did up at Temple University using my patients. He asked me for a series of x-rays for patients over a 2-day period and send them up to severe patients over time, over a significant period of time. And this is digital subtraction radiography. In case you don't know what it is, it's radiographs of the same site at different times, and they're computerized. You rematch the size, and the software matches the density of selected areas of bone on comparable radiographs. Differences in bone density and height are displayed in contrasting shades, and they're quantified. For example, here you see the white areas. There's additional bone here compared to originally. So now the following patient radiographs typify the results of therapy based on microbial monitoring. Everyone had severe, or what's now called aggressive. By the way, I want to reemphasize again, aggressive periodontitis does not occur if you're following the microorganisms, only if you're doing conventional therapy, either surgical or non-surgical. Conventional therapy, neither one will suffice. And stability demonstrates that even with deep pockets, further destruction is preventable. Here's an initial slide. 19D was over 10 millimeters deep. 18D was 8 millimeters deep. And here's 12 years later. You can see there's bone reformation there. I didn't do any surgery on this patient. This is nothing. It just shows you when you stop inflammation, bone can regrow. If you stop infection, bone can regrow. It doesn't always. You at least get stability, though. So bone height and density, here's the difference displayed as the white area there. Here's Number 30 distal was 9 millimeters deep. Now, normally, if you go to our traditional periodontal treatment, you're going to say, oh, I've got to cut that away. I've got to, or try to reattach or add a bone graft there. Well, just good infection control. Here it is 8 years later, still 5 millimeters, but it's controlled. That patient does not have a high risk infection there. I don't know if Dr. Rams is going to publish this yet, but he said he's going to in the near future. I don't know when and where, but he will. 19 mesial is 8 millimeters, and 19 distal is 6 millimeters here. Here it is 8 years later, no change in depth, but you can see it certainly looks better, and it certainly hasn't gotten worse. And this is what concentrating on infection rather than pocket depth, this is what happens. 19 distal, 10 plus millimeters deep, 7 years later, 4 millimeters deep. Same situation here. Tooth number 18 mesial is 8 millimeters, 18 distal is 9 millimeters. And better pocket depths, I don't care if it was the same, as long as it's not worse and there isn't a high risk infection. 30 mesial is 8 millimeters, 5 years later, looks a lot better. Here's a guy that refuses to do anything. And 25 distal was 7 millimeters deep. Here it is 4 years later, it's 4 millimeters deep. He still putters on, and it's not going to change, but that's fine. His major effort at controlling his biofilms is chewing more cigars, but we see him very often every 2 months for maintenance and infection control. Here's an anterior tooth. I should mention, as we're going along here, the one factor that's really problematic is looseness. If the tooth is mobile, if you have a loose tooth, you're not going to get regrowth, and often you're going to lose the tooth. That's one of the big predictors of there's just not enough support left. But this tooth was stabilized, and you can see it looks better 14 years later. It's 8 millimeters, which people would say, oh, that's not good. It's acceptable if it's controlled. Again, 19 distal is 10 millimeters, 18 distal is 9 millimeters. Here it's 13 years later. And again, I want to emphasize, this is one of the few advantages of being old. You have long-term results. Again, 3M is 8 millimeters, 16 years later, it's 5 millimeters. So these aren't short-term results. When you see papers that talk about 6 months or a year, that's not adequate. You need 5 years for most situations, in a paper at least, to really tell whether this is significant on a large number of patients. But here you have long-term results, 10 millimeters. Now it's 5 millimeters. I don't care if it remained 10 millimeters as long as it isn't worse, but here it did get better. Digital subtraction again, here's a 6 millimeters going to 5 millimeters. You can see the bone is much denser at least, and it looks much better. So now, disrupting and destroying biofilms daily stops pathogenic activity. That's the thing we have to keep in mind. It has nothing to do with pocket depths. That doesn't mean you like deep pockets. It just means that your target has to be controlling the infection. And succession to a pathogenic biofilm takes time, depending on that host defenses, usually a day or two at least. So, preventing pathogenic biofilms, we can physically and chemically destroy biofilms and delay biofilm succession. And that's critical to our knowledge right there. We know that we can do this in our offices every day, and we do it. Now, the other thing is, looking at the techniques we've talked about, using a water irrigation with a sodium hypochlorite solution, that is an outstanding preventive measure for preventing both gum disease, periimplantitis, and dental caries, except under old fillings and things, but most early and new dental caries can be prevented in the same way. So microbial succession prevention is very, very important for our patients, and we should be using it. Now, antibiotics, we can use them at times, and sometimes I do. It may be needed, especially for non-compliant patients or evidence of disease progression that you need to stop, or patient pain or whatever. But it is not our primary goal to use antibiotics. There is something called antibiotic stewardship, which all of you should acquaint yourself with. And you will have the opportunity on the site to use the various courses which will expose you to that. Antibiotic stewardship is critical. We're using too much antibiotics, and it's a problem. And there are many bacteria that are now no longer susceptible to the antibiotics. Now, back to systemic disease. And that is, we already alluded to this several times before, and I want to reemphasize that systemic disease can be affected by the oral status of the patient you're treating. Inflammation by itself, periodontal inflammation, is systemic and is significant enough. If you look at the number of square millimeters of surface area that's inflamed around teeth, it's very significant, and it contributes to cardiovascular and other degenerative diseases. That in itself, without even considering the bacteria that we've talked about and their invasion. Once you have gingivitis and early invasion occurs, these bacteria can spread systemically at their leisure. And they infect any bodily site that's suitable for that species to grow in. It can be joint capsules, it can be many, many different places. In the case of oral bacteria, with high-risk bacteria, you'll see treponema, the spirochetes, actually are found in the brains of Alzheimer's victims. And so is one of the other microorganisms, Porphyromonas gingivalis. So, addition to reinfection of periodontitis and peri-implantitis sites, bacteria from microsatellite biofilms, both non-oral and oral, are likely responsible for many diseases. The information on this, which diseases and what extent, this is very new material and has not been adequately explored. We do know that when many years ago, it was found that P. gingivalis and oral spirochetes are found in the brains of Alzheimer's victims. If we use classical microbiology, that is enough to implicate those bacteria. We know now that we need a little more information. We don't know that these are causative, but they are not doing this patient any good at all. For example, spirochetes, oral spirochetes, treponema, that's the same genus as syphilis. And these do the same thing syphilis do. They go to our brains. Obviously, they're not doing any good. And they may well be involved in Alzheimer's and other degenerative neurological diseases of our brains. We already talked about the fact that Fusobacteria can initiate malignant changes in the GI tract, and that's been proven. Now, even though we don't know all the information about the systemic effect of oral pathogenic bacteria, we have to be aware that these are dangerous for our patients. Incidentally, this also means be very careful to use the proper techniques in your office to prevent the spread of these bacteria in large amounts to you and your staff. Make sure you're using all the techniques that you should be using to protect yourself, your staff, and other patients who come in after the initial patient. Now, this is important. We have to prevent these spreads, the systemic spread of these oral bacteria. So What this actually means is when we talk about periodontitis and periimplantitis, we immediately focus our mind on oral tissues, but they are both local and systemic chronic infectious diseases. That's something we're trying to get through to all of us today. And it's very important for us to understand this. Even though we don't have all the information on this, we need to understand these bacteria are not without problems. Okay, now that I've told you this, how do we prevent and treat satellite microbiofilms? Well, as I said before, we really don't have great things at the moment, but there are things that are available that are not easily available at this time, and we'll talk about those in a few moments. What will work to prevent systemic spread? Well, we've already talked about it. The earlier in life that you can get control, the less likely biofilms are to be formed and the fewer biofilms will form. Now remember, even though these biofilms are relatively protected from our immune system, they're not necessarily completely protected. So if they're present, if a few of them are present and there are no active infections going on, our body may over time be able to either wall them off or identify and eliminate them. So they're not without possible systemic immune system reaction long term. But we need to be aware, and this is including when we look at these little kids coming into your office. I don't get little kids in my office unless a mom happens to bring them in. But when we look at them, we have to start saying, what are we going to do to control these bacterial growths on this kid's teeth, not just for dental decay or for periodontitis, but for overall health as well. These are the times we should be using irrigation. And we should be using irrigation maybe with the chlorine solution would be best, or the iodine solution, molecular iodine. And all these things are doable. You shouldn't have any problems with trying to institute these things as early as practical. And you'll later on, Bill Landers will talk to you about a new irrigation device that he has. But even so, use these chlorine solutions or the iodine solutions. Now, the chlorine solution, I find I use it every day, and patients should use it every day. Much more effective than dental floss. That's why water picks are now called water flossers, because they've proven to be more effective than floss. Plus, and we'll get into this in a little while, most people won't floss when you train them to. All right, so right now, to affect these satellite biofilms, the only thing we have is systemic antibiotics, and I wouldn't suggest using this just for the biofilms at this time. But as we know more about them, that may be all there will be at the moment. Systemic antibiotics will help prevent and stop periodontitis only temporarily. You need to do other things, and you don't need them for most situations. And even when you use antibiotic therapy, you likely have not killed either any or all of the satellite biofilms. So keep that in mind. Now, in the future, the technology does exist, but there's a lot of resistance to using the technology of bacteriophage therapy. Now, bacteriophage, these are interesting organisms. And the one you see on the left, I always think of a 1950s science fiction movie. That really looks beautiful. These are viruses that specifically attack particular kinds of bacteria. And every kind of bacteria theoretically has at least one bacteriophage that will affect it. So every species has at least one phage. And these viruses are very effective, and they genetically evolve along with their bacterial targets. So, and they've been around for billions of years. I mean, the first biofilms known are, the oldest fossils known are about 3.5 billion years old. And it's amazing. Viruses were around then too, and these things have been going on for a long time. And these are great little creatures. And they only target the species they evolved with, and they don't destroy any other species, unlike bacteria. When you give somebody bacteria, such as clindamycin, which we'll talk about later, there's no use for clindamycin in dentistry, by the way, and that's emphatic. Do not use clindamycin. It will be a high risk of causing C. diff, Clostridium difficile infections. And these are not good in any way. They can kill people, and they certainly make life miserable. And so bacteriophage, on the other hand, target only the specific species of bacteria, and it works in hours. If there's a particular kind of infection, let's say somebody has a multiple resistant Staph aureus that's causing tissue destruction all over the body, this can work within a couple hours. It'll eliminate all the bacteria of that type, all the Staph aureus of that type, that they will be killed. And it doesn't matter whether they're resistant to antibiotics. These bacteriophage, these virus, make quick work of all the bacteria. Now, if you remember, virus will access a cell by its surface antigens. They'll recognize the cell. They'll inject their nucleic acid into that cell, take over the cell, make a bunch of copies of itself, and burst the cell open. In each of those copies, much, much, much smaller than any of the bacteria, will find other bacteria of that type anywhere in the body. And when there's no more bacteria, it will eventually just be eliminated from you. So it's a very effective way to control these antibiotic-resistant infections, especially. But if you're talking about satellite biofilms, they should be used for that. It's available at this time through an organization locally here in Maryland called Adaptive Phage Therapeutics, which has been was founded by some of the folks at National Institutes of Health. And the story behind this is that the government, the U.S. Navy, has decided that bacteriophage are the best way to fight bacterial infections that may be used in biological warfare. Because, of course, if you're converting a bacteria for biological warfare, it's going to be antibiotic resistant. So they've found as many phages as they can, the U.S. Navy Biological Warfare Defense Lab. And they have phages for many, many, many types of bacterial infections. And I've run into this problem personally. I had a patient who, fortunately, he's a physician, and he understood what we were talking about. He was at Johns Hopkins, which is one of the local universities here. And it's Johns Hopkins calls themselves the best in the world. Of course, I think a lot of people do. And they were treating him for years for a infection of an artificial knee joint, and it had a MRSA infection. And they couldn't get an antibiotic to work. There weren't any antibiotics that would work, but they kept opening it up and flushing it out and using various antibiotics that, of course, didn't work. And they got to the point, this is about 4.5 years ago now, where they said, we're going to cut your leg off. And Bill actually resisted that for some reason. And he said, I don't want that. He told me about this. I told him about bacteriophage, and he contacted this organization. Turns out one of the people at the organization went to medical school with Bill at the University of Chicago, and he was very comfortable with it. And he arranged for them to find a bacteriophage at the Naval's facility, and they did, and they got emergency approval through the FDA. And then Johns Hopkins said they wouldn't do it. It didn't work. This is what we're dealing with. Well, he found somebody else at the University of Maryland who gave it to him. Of course it works. It's a virus. And it cleared up they could not identify that bacteria the next day after injecting this. And so this is a technology that's terribly underused. And I guess because physicians and dentists are not trained to even understand this or know what they are, they resist it. And over time, this will become more usable. And this is something that we could use for any kind of infection, bacterial infection. It's just amazing that it's not widely used. There's no reason that each hospital shouldn't have a freeze-dried container of the bacteriophage that will be useful against MRSA, since it's so widespread, the multiple resistant Staph aureus. And that's when you hear about these tissue-eating infections and so on, these kids losing legs and arms, totally unnecessary. They should just be able to put some sterile saline in it, inject it, and that would be it. But you can't get that through at the moment. I guess the pharmaceutical industry doesn't like the whole idea either. But anyway, so bacteriophage are available, and they, at least to some degree, although not enough. So if you have patients that or family members that need something like this is something you could consider. Now, other viruses can be very useful too. There's a herpes virus being available now that kills cancer cells. A few years back, there was a virus discovered up in Pennsylvania that was called the Seneca Valley virus that attacked only certain kinds of tumor cells. And from that, the idea was developed to develop other viruses to identify the antigens specific for cancer cells and use these virus to kill those cells. And that's new technology. That's just coming up now. And the herpes virus supposedly is for head and neck cancer. So there are some viruses that can attack protozoans, such as malaria. There are viruses that can attack fungus, such as aspergillus and others. And these things really need to be found and worked on. So it's slowly coming into view, but you guys should be aware of bacteriophage therapy as something that can be useful for us in the future. I'm sure it's not going to be out this year or next year as far as being in the in our literature, but hopefully someday in the not too distant future, you will be able to use bacteriophage therapy for some of your patients. So next question is, what can we do as practitioners? And I'm going through this rather fast, I'm afraid. I hope I'm not leaving anyone behind. But if you are, please ask, and we'll get some of these questions. Ask Dr. Rowling can get to me with some of the questions if you have any. But all right. Protocol for monitoring infectious disease. How do we find out which organisms are there? And we'll get into how do we treat for them later. We know some of the things already, but let's talk about identification. Questions we have to ask ourselves: are there pathogenic microorganisms present in a particular spot? And how high is the risk, and which sites are affected? These are all critical questions if you're going to be treating periodontitis. And then third, of course, how are we going to train the patients to eliminate these pathogenic microorganisms? And how are we going to monitor for the reestablishment of these pathogenic biofilms? These are the four questions for us, for therapists, that we have to know the answers for. If we don't answer these questions, we really can't treat these patients. So how do we identify people susceptible to periodontitis before infection occurs? And the answer to that is pretty simple. If you take a sample, a microbial sample from your patient with a brush, and you put it on a microscope and you see high-risk organisms, that person is susceptible to periodontitis. And if they have implants, periimplantitis. And we'll look at the characteristics of pathogenic biofilms again, and the cyclic nature of periodontitis. We talked about that before. As you know, even if you're relatively resistant to these destructive organisms, at times in our life when we're under a lot of stress, and maybe nutritional stress as well, we may not be as well controlled as we'd like. At those times, we can get these high-risk infections growing, and they can cause destruction. So cyclic nature of periodontitis, you've all heard of this, and that's when you have decreases in your defenses, and that results in spurts of destruction when these more destructive biofilms are able to grow. Now, not all periodontitis is the same. That should be very clear to you. We've talked about that in detail previously. So if you have even lower risk microorganisms, now they may not be going downhill as rapidly, but they still are going to go downhill. So we need to know how to identify these various status situations. Now, overall, about 2/3 of periodontitis patients have relatively low risk to susceptibility to these aggressive infections, the highly aggressive infections. Now, that doesn't mean, as I said just now, some of these patients over time, a good number of them, may have a lower resistance and may actually move up into that high risk status and then move back down again at a later date. You don't want to miss that either, and that does happen. And they're usually, even with traditional surgical and non-surgical periodontal therapy, basically as long as you did maintenance, did nothing else, just periodontal maintenance, that's enough to control these people unless they have a high-risk infection at that moment. Now, the microflora of these slower progressing diseases is called orange complex, and there's some less than that, but orange complex organisms. And these are less aggressive than the high-risk red complex bacteria, but they are still there and they are in need of control. They become less controlled with more aggressive bacteria when defenses are periodically decreased. And that time we call them aggressive periodontitis patients. And traditional techniques will not control that. So these highly susceptible, destructive disease patients have to be treated specifically for their high-risk infections. And as I said before, in these patients, in anyone with a high-risk infection, any of the conventional non-surgical or surgical therapies will not control them. And there's terms such as refractory periodontitis and more recently aggressive periodontitis that have been applied to these diseases. And that's because they're not stoppable with traditional treatment. So these people are more genetically susceptible and tend to have red complex bacteria, the most aggressive. Now, the ones that are cyclically down at a lower level, they're not necessarily genetically as susceptible, but they have to be monitored and make sure they're not going downhill. If you train them properly to control and destroy marginal and sulcular and even deep pocket biofilms, they should never have this problem. That's assuming they do these things. Now, these more susceptible people are controllable by monitoring and treating for the high-risk microorganisms. And as I said, monitoring. You must monitor all your patients for these high-risk infections and even moderate-risk infections. They have a right to know if they are susceptible to these diseases. And very easy and inexpensive treatment is available for them to control these infections. They don't have to go through a $15,000 or $20,000 laser treatment. Most people don't, very few. The red complex species has three major groups, and you've all seen these: Porphyromonas gingivalis, Tannerella forsythia, and the Treponema denticola, and there's several Treponema species, several spirochetes that can be present. These are the hardest ones to grow, by the way. You can't, if you send away cultures, they won't be able to identify them. And some of these Treponema, when you send for DNA probes, which I'll talk about in a few minutes, they won't be able to identify all the Treponema either. Some of them they can. So how do we test for these pathogenic microorganisms? And the easiest and most direct way is phase contrast microscopy. Anaerobic cultures are useful too, especially if you want to know the antibiotic resistance of a particular organisms. There's something called the Banna test, which, as you saw a diagram of here, which Walter Loesch developed about 30 years ago, which I don't think is very useful. It's it takes several minutes, and you test, and you put a little dab of the biofilm onto the surface of this test strip, and it turns blue. Well, it doesn't always turn blue, and sometimes it's minor, so it's very difficult. I wouldn't suggest using Banna. But DNA testing, and anaerobic cultures are useful. Bannazyme, as I said, I wouldn't use. Phase contrast microscopy is the most useful of these technologies. And it requires a microscope and a monitor, very inexpensive compared to most of our other dental equipment. And it's very fast and very inexpensive once it's set up. Less than 15 cents a sample or 20 cents, depending on inflation now. You can do 2 samples per slide, which makes it about 7.5 cents. And it's highly motivational for patients. When patients see this, they're very stunned, usually. You can test for multiple individual sites in a very short time. I can take samples from 6 or 8 sites in 10 minutes or less. You get immediate results. Now, the microscopic changes for a biofilm. When you see a healthy environment, you should have a few cockle-shaped bacteria, ideally, and very little motility. As you get less controlled, more infection, more high-risk infection, you get more motile organisms, meaning mobile, and you get longer organisms. And eventually, if you get high risk, you'll see spirochetes and others. And I'll show you some examples of this in a few minutes. And you get an increased number of white blood cells as it gets worse. But that can be misleading because white blood cells can be there from traumatic brushing techniques. The presence of protozoans such as amoebas and trichomonads, that's also a good indication of high risk. They don't occur in low risk biofilms. And presence of long motile rods in particular. Now this is aggressive periodontitis. Let's see if we can get this to work. Yes, there. Now you can see there's a biofilm at the lower 2/3, including many amoebas stuck in there. And at the top you see spirochetes, corkscrew-shaped bacteria that are spinning around. This is a high-risk, aggressive infection. Very, very nice to look at. And patients, when they first see this, are very impressed. Here's another view of what it might look like when you take just going in with a toothbrush. You don't even have to go deep. Usually you get these very easily, sampling with a brush. Let's see, aggressive periodontitis. Let's see if we can get this one to work. There we go. Now you can see a lot of motile rods here in addition to the spirochetes. Those are not good either. And there's a biofilm below with amoebas stuck in those blob-shaped jelly donut-looking things. And again, now this is health. Oh, how did we get to health? Okay. You can see much different situation, very clear. There's not anything wiggling around. Everything is floating up because the fluid is evaporating slowly. There's a white blood cell in the upper right, but this is what health looks like. It's a very different situation. Sometimes when I'm showing a patient techniques, how to clean a 10-millimeter pocket, for example, I'll go in with a Proxibrush, which you'll learn how to do in a few minutes. I'll go into a vertical Proxibrush used to get down to the base of the pocket and just wiggle it around. Take that sample, put it on a microscope slide, wash the brush, go in there and do it again just to make sure I've done it well. And then go in a second time and take another sample and compare the two. And they'll see on one sample, you'll see the high-risk infection just as we saw it before. And this is what the second one will probably look like. It's very dramatic and very easy to help people understand what they're trying to do. Now, phase contrast microscopy does require training and experience. And if anyone decides you want to do this, and we'll have a slide at the end of our presentation, you'll contact Mr. Bill Landers at OraTec Company, and he'll arrange for the both the equipment and training. I'll work with you as well as other people who are experienced in microscopy. And long term, we'll keep track of you, and you can send videos to us, and we'll help you interpret both a microscopic appearance as well as what you might want to do for that patient. So there's OraTec's phone number again with Bill Landers' name. Okay, the advantages of microbial monitoring, we've actually gone into that a little bit. We can determine the aggressive potential of a specific patient's disease before destruction occurs. You have a 15-year-old kid in there who you take a sample with a small tufted brush, or because they won't have room for a proxa brush, and you put it on a microscope slide and you see the spirochetes as we saw before. Show it to them, and tell them you need to use a water pick with a chlorine solution, use a stimulant or other interdental technique gently to get in there. You don't want to be aggressive about anything. You want to use a low trauma toothbrush like a sonic brush where the bristles just vibrate without causing any significant friction, which causes a gingival recession, of course. You don't want that. And toothbrush abrasion. All right, so we can determine aggressiveness of a particular patient's biofilm even before they have any periodontitis. And then if after treatment you use the same technology, we can show them how they've eliminated this problem. It's predictable control. Very easy to do for your patients, very effective, and you'll prevent future disease. That's what we need to be doing. As I said, love to have a prevention program in our area, and I've talked to Dr. Rowling about this, and we're going to try to see if we can set one up using the hypochlorite solution, if possible, with water irrigators for a local population, and see if we can have an effect. It really is very disturbing that we as dental professionals have not done this in the past, partially because we haven't really been exposed to all this information that's out there. We're exposed to bits and dribbles of it, but not to the extent that we need to in order to really understand what we're dealing with and what to do. But we could prevent much of the periodontitis and much of the caries in our patients for their future. And this is especially important for low-income people who may not be able to afford dental care or very much dental care. Why should we let these patients go downhill when there is a potential for them with very little expense to control these infections? Very, very important. And I can't overemphasize the fact that we need to be doing a lot more than we are for our patients to prevent these biofilms from causing both local disease and systemic infections later, make their lives better. Now, microbial monitoring, there's no other way to accurately and rapidly determine which sites are at risk. Even if you know that there's a high-risk infection and it's not everywhere, you need to identify which sites that person needs to be targeting and what you need to be targeting in the future for looking at and for determining whether the infection is controlled in those sites. Refractory and aggressive periodontitis only exists when we don't monitor for pathogenic bacteria. And that's very important. These are controllable infections, and we need to do it. With an anaerobic culture, and we have some of the culture labs that are available. I put them in here for you. It'll identify most pathogens, not spirochetes, and give antibiotic sensitivity for the spectrum of pathogens if it's a hard to control infection. And here's University of North Carolina and University of Southern California. Here there's phone numbers for anaerobic culture labs. They'll send you the kits and with some instructions on how to take the samples. Okay, so which subgingival bacteria we're dealing with? Are we looking for microbial sampling? Of course, DNA probes will tell us that too. We talked about the advantages and disadvantages of all these things. Oral DNA labs is one of the salivary DNA labs that you can use to take samples. All you have to do is they basically they spit into a tube and you send that to the lab and they'll send you back a report telling you what's growing, what levels, and so on, and they'll give you an idea of what antibiotics may be useful. Now, this is something we talked about earlier that we want to concentrate on now: traumatic periodontal tissue destruction. Hard and soft tissue trauma can be due to traumatic brushing and flossing and polishing. When we talk about polishing, we're all trying, oh, we've got to polish it. It gives that nice smooth feeling. Well, it's harmful. Every time you polish, you're removing a significant amount of enamel, and that person will have more discolored teeth as time goes on than they would have if you didn't polish. And if you've done a good maintenance appointment, especially with ultrasonics, we use molecular iodine as a coolant for our ultrasonics, which I think is a good idea. It's a very good killing agent, and it doesn't have any taste or color. It basically, they put a sour apple flavor in it, which isn't bad. All right. So soft tissue recession is the most obvious result of traumatic toothbrushing techniques, both on the facial and lingual and palatal surfaces. And we were taught in our residency, every time you have recession, jump in and do a graft. That's crap. You don't need to do that. If you stop using destructive techniques, now, if you have a lot of recession, let's say in a lower anterior tooth, and if you're using a sonic toothbrush, which you should be using rather than anything that spins or scrubs, just push the brush gently to the gingiva, let it sit. The vibration will cause sonic waves that will break up the biofilm, the local biofilm, followed by the irrigation with the water pick with the chlorine solution. That is very effective. Anyway, if you're snapping floss up there, you're going to cut the gums, and if you're going side to side, you're going to cause grooves in the teeth interdentally. And for toothbrushing, you're going to cause recession and toothbrush abrasion, which are sensitive. Then you have to treat them. Unnecessary. You don't need to do grafting most of the time. And when they're unable to get the brush down to the delicate area that no longer has attached gingiva, teach them to use a rubber tip to go around and remove the biofilm in that recession area, followed by the irrigation with a water pick with the hypochlorite solution, as we discussed. And as we mentioned before, traumatic brushing, even with a proxy brush, which we'll talk about using in a little while, if you go in and out, that's bad. Every time you go in and out, you're causing a lot of trauma, a lot of energy is released by going in and out. And flossing and traumatic brushing, interdental brushing, and toothbrushing can cause a lot of tissue damage. And as I said before, the inflammation caused by these brushing and flossing will cause adjacent bone loss. So friction from sliding bristles, especially with abrasives like toothpaste or polishing paste, will remove both hard and soft tissue. So do not scrub in any way with a toothbrush. If you're using a regular toothbrush, use that old Bass technique. Just gently push the gums and jiggle the bristles in place. That will do a great job. If you're scrubbing side to side, it not only causes more friction and cuts gums and teeth away, but it doesn't get around the curvatures. The bristles flow in the direction opposite the pull, just like a paintbrush. And when you're doing that, all that energy is released right at the outside circular part of the teeth, that tangent of the teeth, and that's where you're going to have the recession and toothbrush abrasion. Totally unnecessary. So the more sliding bristles, the worse everything's going to be. Rubber cup when polishing, as I mentioned before, unnecessary. We tell people that we'll polish if they want. We won't charge them anything because it's of no use and it causes damage. When I say damage, both removal of enamel and that smooth feeling that they have on the enamel after you've polished. Yes, they've removed the pellicle, but the pellicle will reform in minutes, and you'll start getting a biofilm reforming in 15 or 20 minutes. It doesn't matter whether you polish or not. So you're not doing any favors to these people. You're just going to make their teeth darker, less enamel over time. So initially, significant enamel is removed by polishing, in causing tooth color changes and even sensitivity if you expose dentin. So now we get the nuts and bolts. What do we do? What do we tell patients to do to control these infections? Hopefully everybody knows at this time you've got to identify whether or not that patient has a high-risk infection and whether that infection is growing everywhere or just in some places. So for preventing periodontal progression, as a guide, the things I'm going to talk about today, we've found to be useful in our office. And I've developed that technique for both horizontal and vertical proxibrush use. Horizontal use when there isn't much pocket depth, 4 or 5 or 6 millimeters, it's going in between the teeth, compressing and coming out. The bristles, when you're compressing, will disrupt the biofilm at the gingival margin and slightly subgingivally. Going in and out, the bristles will flatten out and they won't even do that. They'll just cause more destruction without necessarily destroying the biofilm. Then hitting it with a water irrigator at high pressure using the flat tip. Don't use that little rubber thing that comes with some of these irrigators. That just flaps around and they're not going to get these things into the pocket. Just squirting between the teeth at high pressure, that narrow space will set up a little Bernoulli effect that swirls the fluid under the gums. And it's been shown, as you know, at least halfway down to the base of even deep periodontal pockets. Now hold it in place at least a second or two in each interdental space from the outside and inside. And tell patients to hold their elbow inside the sink when they're using an irrigation device. That way, when the fluid comes out of their mouth, it'll flow down their arm into the sink rather than on the floor. Using that, after disrupting, using the water irrigation with the chlorine solution will kill the bacteria that are now exposed even better than they were before. So the goal is just to have an early growth biofilm in all oral sites after treatment, not let that biofilm develop into a pathogenic biofilm. The patient should gently be using these techniques to disrupt that biofilm every day and not let it regrow. Now, what about prebiotics and probiotics? Well, prebiotics and probiotics are probably useful. We know they are useful for certain things. For example, when people have a Clostridium difficile infection, the most useful technique has been probiotics, using what's called fecal implants. They used to have what they called poop pills, that they put the bacteria from the feces in these little pills and people swallow it and reestablish a normal flora in that person. Same with prebiotics. Now, the problem with probiotics is if that person's environment under their gums or at the gingival margin is such that it allows a high-risk microflora, if you don't continue to use the probiotics, the high-risk microflora will again develop. So it may be of use short-term, and that may be something we can consider. We just don't know enough about it yet at this time. But keep your eyes on information about probiotics, and it wouldn't be a bad thing. They don't cause any problem. We've already talked about bacteriophages. Those are the most effective way of killing specific kinds of bacteria. And wouldn't it be nice if we had a package of bacteriophage in a small container that we could even squirt under the gums a little bit, and it'll kill all the bacteria, or give a small injection, I should say, and kill all the bacteria that we're trying to kill. Not just kill the bacteria, but kill the satellite microbiofilms anywhere in that person's body, so they won't be reinfected by these same bacteria. Unfortunately, that's not available at this time. Now, systemic antibiotics can be used and should be used when necessary for less controlled situations, but don't overuse them. You don't need 2 weeks of antibiotics. Now, usually 5 days is enough, and you can monitor it afterwards to make sure. Now, once the patient has learned how to prevent pathogenic biofilms, they can actually achieve that by themselves. People doing this don't have to be seen every 3 months. They can be every 6 months, every 4 months, whatever they feel comfortable doing, whatever you feel comfortable. But keep monitoring them to make sure that they're maintaining the status as they should. So once a year, they can be seen for microscopic analysis, which has to be done. Take samples from all over the mouth and you can put them together and see if there's anything there that shouldn't be there, and work with them on maintenance. We have, when a patient comes into our office, we initially charge them for a bacterial control program. And it's not that much. It's like $250. It's as many appointments as they need, usually 2 or 3 appointments, short ones usually. What they need to do for that specific patient, whether they need to use the rubber tips, and whether there's room for a Proxa brush, all these things need to be looked at and adjusted for that particular patient. And we don't charge them later if we need to go over these techniques again for a few minutes at a later date. So, but now the maintenance appointment is always, we use subgingival brushing first, followed by ultrasonics with the iodine solution as a coolant, as we said before. And basically, we want to destroy every biofilm there. If it's an implant, I know you hear about never use anything on an implant that's going to scratch the surface. These biofilms grow on scratches or not scratches. But usually with an implant, you can get in there gently around from the facial and the lingual or palatal surface and destroy most of the biofilm, and with the iodine solution as well. Now, prebiotics and probiotics, here is a recent publication that you might look at that'll talk a little bit about that, and that's from Journal of Periodontology, which is available at this time. It's from 2023. So they will be effective. Bacteriophage will be great if we have them. Unfortunately, because of ignorance and dogma and arrogance and pharmaceutical opposition, they're not available yet. Antibiotics, shortcomings and danger with it, and they are useful. Remember, antibiotic stewardship, and Dr. Rowling, I think, has courses in her repertoire right now that will go over antibiotic stewardship. Very important. You don't want to get into a situation where you're causing your patients a big problem and much damage and danger. Always monitor pathogenic flora after antibiotic therapy if there's any question about effectiveness. And even if there isn't, go in and do it. It doesn't hurt. And you can use DNA probes and so on. I think the microscope is much more effective, and it doesn't cost much. If you do a DNA probe, you're going to have to charge your patient about $180 or $200. Anaerobic culture about the same, and that's just for one spot. The DNA probe is the whole mouth, but you can't identify any particular spots. So the microscope is the best way to go. Now, if the flora is not responsive, if you don't know what else to do, give me a call, of course. And if we can't figure it out, then worry about culture and sensitivity. Try not to use antibiotics more than once or twice a year, if that. I'd prefer not to use them that much. Increase maintenance rather than using antibiotics whenever practical. The most commonly used antibiotic for the kinds of microorganisms that we're dealing with are metronidazole with or without amoxicillin or augmentin. Now, the problem with both metronidazole and augmentin is that they cause stomach upset. So have them use this with food when they're doing it. Metronidazole alone too. The other thing, if you're going to use metronidazole, if they have any neurologic problem, don't use it. It's just, you don't get into any problems. Make sure whatever antibiotic you're going to use, that you look at the side effects and what the problems can be before you use them. If you're going to use a Z-Pak, don't use it on people with any kind of heart conduction problem, because you could cause death. As I already talked about, clindamycin is never indicated in dentistry for anything. So don't ever use clindamycin anymore. Topical antibiotics, we've had these things just work. It makes no sense. If you're going to use an antibiotic, you want to access all the tissue sites, not just the sulcus or pocket. You want to get into the tissue. And the evidence on this is extremely sketchy, by the way, but don't use them. Patient self-care, which is probably one of the most important things that we can do for a patient. As a general guideline, always use as few techniques as possible to achieve low friction biofilm disruption. Don't automatically teach everything that you have in your armamentarium. Just the fewest things you need to do to achieve your goal. You're more likely to have a good result. The toothbrush, we already talked about this to an extent. Powered toothbrushes are more effective than hand brushing. But if you hand brush using that little bash technique, that's reasonably good, especially for people who don't have enough money to buy a powered toothbrush such as a Sonicare. Avoid ever sliding bristles across a tooth surface. And we talked about this in more detail earlier. Every time you slide a bristle across the tooth surface, you're going to cause some damage, microscopic damage, but over time, you're going to have recession and you're going to have toothbrush abrasion, both unnecessary. And most recession, if you train people not to cause any more damage, it will stop where it is. Adding a graft is not going to add more bone, by the way, and it's just costly and uncomfortable. If you need it, but that's much less often than we thought in the past. Remember that when you're sliding a brush, it acts like a paintbrush. The bristles move in the opposite direction of the pull, and you're only going to hit the biofilm on the facial surface. You're not going to get under the gums at all, and you're not going to get interdentally. So anytime you're using a spinning brush that's rotating, it's spinning around or going oscillating, or hand brushing by scrubbing side to side, you're causing damage and you're not doing as much good as you can. So you're not getting around line angles or the curve, which brings up another point. The shorter the brush, the better. When we have people using a sonic brush, we have them buy the child-size refills. The reason for that is the longer the brush, we'll look at it that way, the longer the brush, the less likely you are to get around the curvatures of the teeth. So the shorter the brush, the better it is. Spinning, scrubbing brushes can't adapt around line angles compared to sonic brushes unless you push real hard, in which case you're causing a great deal of damage. They'll remove marginal gingiva and tooth surface. Sonic brushes tend not to do that. And remember, when you're scrubbing with a spinning brush or using a polishing cup, that smooth feeling is because you've sanded off some of the enamel. You've not only removed the biofilm and the pellicle, but you've removed some enamel. Not a good thing. Dr. Karen Mortensen works with me, and I have done some work with looking at the abrasiveness of sonic toothbrushes versus spinning toothbrushes. And we have not published this, we've found that the spinning brushes cause 6 to 7 times as much surface removal of tissue, or I wouldn't say tissue, of hard tissue, more 6 or 7 times as abrasive as a sonic brush. So high friction brushing is the cause of gingival recession and enamel loss and the need for tooth whitening. Of course, if you want to increase your tooth whitening business, I guess that's the way to go, but I wouldn't suggest doing that. Okay, only low friction is needed for biofilm disruption. And remember, if you disrupt the biofilm, it has to start growing from the beginning. This is a sequential growth. This is succession occurring. And it'll take a day or two for aggressive bacteria to regrow in that biofilm at the very least. When you stop causing excessive friction, recession will stop. And we've seen this over time. So again, here's one of those ideas that works better with old folks like me. I've been at it long enough to see these techniques work. You don't need to be scrubbing teeth that causes damage. Gingival grafts are rarely needed. Now, the sonic toothbrush effectively disrupts and removes biofilms up to 1 millimeter away from the brush tip. The bristles are moving very high frequency but low amplitude. They're not moving much. And as I said, they cause a sonic wave. So we usually have people buy a child-sized sonic toothbrush. You can get them at locally here, Walmart and these other places. We have them in the office too, but you can usually get them on sale very inexpensively. Much less destruction and friction than spinning or scrubbing bristles. The other advantage, as I said before, it readily accesses around line angles. You can have them put it in place at the gingival margin, and if they want to, they can rotate the handle outward and inward slightly to rotate the brush to aim backwards or forwards. And that will get around. And make sure they're getting behind the last tooth, both with the brush and with the water irrigation. Now, it may not remove all the pellicle, so it may not feel as smooth as high friction brushing, but it does a better job and it won't cause damage. Now remember, the pellicle is not pathogenic in itself, and it's going to reform quickly. It doesn't matter what else you do, whether you're brushing or polishing. That pellicle is going to reform within 10 to 15 minutes. Smaller the brush head, the more proximal access. Again, we use the Sonicare with the child size refill. For interproximal sites, traditional flossing, we'll go over that again. The problems with it is it can't access subgingivally, and it leaves supragingival biofilms interdentally. And this is especially true when there's any root surface exposed from periodontitis. It's not going to get into the concave surfaces. in addition to that, the flossing will only be used by about 15% of the people you teach to floss, which means you have an 85% failure rate in using the interdental cleaning technique. Not a very good idea. So we were all trained, and it's still training people to floss and brush in dental schools and dental hygiene programs. I don't quite understand it, but new ideas take time to penetrate into teaching. So it's difficult. Only a small percentage of patients will routinely floss, and most of the people that floss do it aggressively. These are people that are obsessive compulsive, and they will cut their gums, and that causes bone loss, among other things, and also causes cuts of the tooth itself. And it's not useful for people with periodontal pockets or exposed roots, and it will cause damage. So dental floss, I think, is something you can tell people not to do. I believe it. And there are easier and more effective methods for interdental, interproximal biofilm disruption, especially, as I mentioned many times before, irrigation with the hypochlorite solution, even without hypochlorite. So this is the single best biofilm control technique your patient can learn to do. As I said before, we should be using it much more for prevention as well as treatment. I can't emphasize enough, we need to be preventing disease rather than just treating it. It's the single most effective interdental infection control technique. Water itself has been shown to be effective, but not nearly as effective as the hypochlorite. So I tell people they have to use hypochlorite. They can't just use water if they have a tendency to have high-risk infections. Now, they always use warm solutions when you're doing this. When I say that, cold solutions in the water irrigator are very uncomfortable. In addition to that, when you warm solutions up, if you remember from basic chemistry, when you increase the temperature of a fluid by 10 degrees Fahrenheit, you have an approximate doubling of chemical activity. So using warm solutions is not only beneficial from not causing pain, but it's beneficial from the effects of your irrigation. So what you have people do, bleach comes in these, let me get back, I'm sorry. Well, we don't need to. Bleach comes in large bottles, and it doesn't matter whether you use a regular or concentrated bleach. Sodium hypochlorite is the active ingredient in bleach, and it's exactly the same as used in swimming pools. It's exactly the same sodium hypochlorite that's used in water treatment plants. As I said before, it's why we don't get these enteric diseases like cholera. And it's very good at rapid killing of bacteria. So when people get a gallon jug of bleach, you don't want to put that on the side of your countertop. You want to take a small, good plastic bottle, for example, a bottle from vitamin pills, and put some bleach in there and cover it up. Sodium hypochlorite is very volatile and it will vaporize quickly. If you leave the cap open, it'll be there'll be no hypochlorite. It'll be just water after 20 minutes or half an hour. So cover it up well, and when you need it, you put the water irrigator container in the sink, put a half a teaspoon of chlorine bleach, if it's a 1 quart container. Put half a teaspoon of bleach and put warm water in. Make it warmer than you think you need, because it has to go through those little tubes. So make it hotter than you think you need. If it's a container that's less than a quart, usually they're 1 pint, the smaller ones, use a 1/4 teaspoon. Use measuring teaspoons from the grocery store. They're very inexpensive, little plastic ones. And just put it in the water irrigation reservoir, fill it up with warm water, and use that. Keep your elbow in the sink when doing it. I told you about that before, so that you don't get it all over the floor. They do not have to rinse afterwards. It's not going to hurt to swallow it. It's the same level of chlorine as swimming pools can be, so you can swallow it. You don't have to, but it will kill bacteria very, very effectively. You can use it for the top of the tongue, and people who have fissured tongues. Ideally, the top of our tongue is a reservoir for bacteria, and if it's a flat tongue, using just a tongue scraper or a tongue brush will be adequate to remove the biofilms from the top of our tongue. If they have a fissured tongue and they want to, they can use the water irrigator, and there's actually a attachment on most water irrigation devices that you buy that you can use on top of your tongue after you've done the gums. But doing the top of the tongues is important as well. Now, bad breath. Now, bad breath can come from bacterial biofilms. As I said before, they can have all kinds of pathogenic bacteria that smell. These are bacteria that are metabolizing tissue and tissue fluids. They're basically rotting bacteria. If you have enteric bacteria growing, it smells like feces. So all these things can be killed by the techniques we're talking about. One of the advantages of chlorine, even in an intact biofilm with a protective covering, chlorine penetrates into that and will kill the bacteria in the biofilm if it has access to the biofilm. So it can access into biofilms even if you miss them with the supra and subgingival mechanical disruption. And especially if you've done that effectively, there's not a lot less, and it's more likely that you're going to have a very good result. And again, no other antiseptics is remotely close to speed and effectiveness of killing bacteria, as well as fungus and virus. Swimming pool level of chlorine. Iodine, molecular iodine, is close. I don't know that it's the same. It's not been tested in the same ways. But it is a good substitute if somebody doesn't want to use chlorine. And I think Dr. Rolling has courses on the use of molecular iodine, both as a coolant for your ultrasonics as well as for patient use. It's a critical technique, and it's preventive, as I said many times before, for caries as well as high-risk periodontal infections. So it accesses at least halfway down into the pocket and delivers antiseptics, and that's really pretty critical. In addition, it not only eliminates accessible biofilms, but when you're squirting that in there, it adds oxygen. Many of these more aggressive bacteria are microaerophilic. They call them anaerobic. I'm not sure if anaerobic is the proper term. And this is because there's always going to be some oxygen in our mouth. But it does remove the metabolic and inflammatory byproducts as well as kill the bacteria. Adding oxygen can only help prevent the growth of microbial biofilms. So the chlorine, again, radically changes the marginal and subgingival environment. It reduces caries risk from supragingival biofilms as well. Now, the one problem, as I mentioned earlier, was if you have supragingival caries forming under old fillings, I'm not so sure how accessible that is for just simple high-pressure irrigation. That is a problem. And so it's important to keep track of those open margins, for example. When using the high pressure irrigation, as I mentioned before, always use the classic flat irrigating tip. Don't use the little flappy device, that little rubber cone that comes on the end of it. This is the tip that's called the classic tip. It's the one that's been tested most often, and it's very effective at getting under the gingiva. Again, molecular iodine, a reasonable substitute, but it's much more expensive. If you have patients who are poor, that is a problem. Saturated baking soda, it's not as effective, but it can be used. This is something that was developed many decades ago and probably has been used for at least a century, probably more than that, by people in remote areas. They brush with baking soda or push the baking soda between their teeth. And saturated baking soda can be used in the water pick. It's not nearly as effective as iodine, and it's not as effective, certainly not as effective as the chlorine solution. And it's also a very big mess to mix up. You mix up a quart of warm water with as much baking soda as will dissolve in it, put that in your water pick, and then have them run clear water through. By the way, whatever they use in the water pick, have them run clear water through for a second or two at least after they're done. That will prevent the inside of the water irrigator from becoming salted or destroyed. Let's see if we get beyond that. Okay, so now we're going to go into, we talked about irrigation and toothbrushing, and what do patients do interdentally to disrupt the biofilms? And one of the things you have to remember, always check your new technique or any tech. If you're using my techniques or you're using new techniques, always check them with a microscope after you've done. This is especially true of the deepest sites. So we're going to talk about interdental moderate to deep techniques up to 14 millimeters. How do you disrupt the biofilm? Now, horizontal and vertical proxy brush, we always use the number 614 proxy brush tip. This used to be the Butler product. Butler was bought by GUM Corporation, and it's kept the same name. Proxy brush handles are changing, the tips, but the long handle, if you can get them, and the 614 tip is what we use, and this is what it looks like. Sunstar used to be, I think it's now GUM, and long handle is best. Very difficult otherwise. Now, when you have this Christmas tree shaped brush going into the gum pocket, it will disrupt a wide area, and it's very effective. Ideally, you want to disrupt the biofilm in the entire periodontal defect. Now, if there's not enough room between teeth because of restorations or crowding, don't try to force it in. There's other techniques that we'll talk about. Now, most people with periodontal disease will have enough space. And the horizontal proxy brush technique, which we'll go into now, is used for, it's useful for 5 to 7 millimeters deep. Again, test this out if there's any question in the microscope. What we do is we gently wiggle the proxy brush into the interdental space in the same direction as the tooth contact from above. Never ever used an in and out stroke. Just go in, compress it towards the gingiva, and then come out. That will let the bristles straighten out, and they will, pressing it down against the side of each of the two teeth, will access certainly 4 to 5 millimeters, and probably even deeper than that if it's done properly. And this is what to do. Brush is going in, comes out the same way. You notice he compresses it against the side of the teeth, comes out from the lingual too, if you can. Usually for most people, just from the facial is enough. And don't forget behind the last tooth. Okay, so that's all there is to it. The problem is, I've got this patient's mouth open. when they're doing this at home, have them close their cheek. Otherwise, the cheeks will pull against the brush and it makes it much more difficult. So if their teeth are closed, they have them look at the top of the tooth and see the angle of insertion and go straight, wiggle it straight in, compress it to the gingiva and wiggle it straight out sideways. When they're first doing it, they'll try to pull the brush forward or pull it occlusally and it'll get stuck. So going straight in the direction the contact is and coming straight out makes it much easier for patients. And you can do this anywhere the patient has space, usually molars and bicuspids, sometimes on anterior teeth, but usually not, and behind the last tooth as well. Vertical proxibrush, let's say you have some deep spots and into class 2 and 3 furcations, you can even do it in that. Distal to the second molars where there's been a third molar extraction, you have a deep pocket. Always keep the tip of the brush on the tooth, as you'll see in a moment. Wiggle the bristles while you're inserting. That helps the bristles, that brush, get into the defect. Here it is behind the second molar. Tip is on the tooth. Just wiggle it down, go side to side. It'll bleed when you're first going in there because remember, the biofilm causes the inner lining of the gingiva to be de-epithelialized. So that's what the bleeding is. Once they've done it a few times, it will not bleed anymore. So again, put the tip of aim the brush a little bit forward, keeping the tip on the tooth, and then just let it go down with the tip on the tooth. Not easy to do when you're first doing it. And come out. Now, if you were to sample that under the microscope, you'd see a high-risk infection. And then do this and sample a second sample, and you'll see a vast difference between the two. For vertical proxibrush, I should have done this with, you notice I'm going about 50 degrees up. It's about an 8 or 10 millimeter pocket. And just put the tip on the tooth if there's a deep spot only in one place. And just wiggle it up. The bleeding will stop once they've done it a few times. And you're going up and disrupting the biofilm before doing the water irrigation. And again, (45, 55 degrees up from the inside and the outside. And you can get into furcations the same way, keeping the tip on the tooth and the facial surface halfway along the tooth if it's a facial furcation. If it's a palatal furcation, they can just go almost straight up from the palatal side and get into the furcations. A warning, not everyone's going to do that. So don't expect miracles, but this is a way they can learn to control deep biofilm infections. This is into a furcation on the facial surface. Going in, just go in a circle. Come out the same way. The lingual surface would be exactly the same. So easy furcations for lower molars. Same for upper molars if it's on the facial surface. The palatal on the upper molars is the most difficult spot for most patients, and that's a spot many people will not try to control. Here's another view from the inside, from the palatal side. Notice we're going up almost vertically, wiggling it up into the furcation, go in a little circle, come out. You can destroy it as far in as you go, the biofilm completely. Again, put that tip right on the tooth, wiggle it up into that furcation. You can do it from the distal surface of that tooth as well when needed. So these are techniques that have been proven to be effective. Dr. Rams and I have published, and it's in that bibliography. So the things to remember is once you insert the brush into the defect, you rotate it and kind of wiggle it around to get to the full extent of that defect, whether it's a furcation or a vertical defect on the proximal surface. These are techniques that do work. And if you're asking me, does it work on every single case? No, but almost everyone. You can usually find a way to do it. There are some spots where it's not accessible, and that is, let's say around the line angle, tight areas on the palatal surface of a maxillary molar. Those are not easily accessible with a proxa brush. Small tufted brushes can also be used to go into these narrow spaces that are not, this is not a very, the present availability of small tufted brushes, most of them are not very stiff, so it's hard to do this. But it might be useful for some spaces. And this is a small tufted brush just going into a deep defect and brushing around. And the brush we used to use was made by a brush company in Britain, which no longer sends them over here. Now we have the things that we get from the Shine Corporation that are kind of flimsy, but they can be used in isolated situations. For most people, these brushing techniques under the gums and so on take 2 to 4 dedicated appointments. That doesn't mean that you're doing something else and you just spend a half a minute with them. They actually come in for 15 minutes or so. You don't review everything. Just try to be as concise as possible, as few techniques. And if you're reviewing the vertical technique, for example, sit there and with your headlight on and give them a mirror and let's see them do it. Watch them do it. Find the deep spots, tell them where they are. When they're first learning the deep techniques, just find 1 or 2 spots. So they learn the techniques. And after that, they can learn where all the deep spots are. But until then, show them it, watch them do it, hold their fingers if you need to when they're doing it, and then watch them do it by themselves a few times, and then come back a week or 2 later, whatever it is, and show you again. As I said, most people, at the most 3 or 4 appointments is enough. And this is the critical part, training them to control well. You don't just say floss and brush. That doesn't work. You have to work with them, and your staff has to know what they're doing. And again, something I don't do enough, I don't review and standardize myself enough with the people I'm working with, but it is important. I want them to know you don't go through every detail of everything that you have. This is what that patient needs for this spot, and that's all you need to do. When you're using a small tufted brush, you don't crush it against the tooth. You just put the bristles against the tooth very lightly to get a flat surface, and then push that up vertically, jiggling it into the whatever defect it is. And hopefully you can get up there. And then follow it up with the water pick, as I said before. So all these techniques require specific training both for the patient and for the therapist. You cannot just say do this or do that and give them a handout. I do have handouts on this, by the way. Now the other thing is, now I've just shown you some of the techniques we use, and there are other techniques you may want to try on both shallow and deep areas. Always check the effectiveness with your microscope. If you're serious about this type of technology, about controlling biofilms, you cannot just tell them to do things and take it for granted. The microscope is very, very important in helping you determine whether your technique is being successful, or in fact, whether the patient is being successful. Irrigation syringes and stimulants, we'll talk about that. These are some products that we have locally here. I don't know if they're worldwide or not. I think they're in somewhere in Europe, but these packages have an 800 number, and you can call up and find out where they are. There may be similar products elsewhere. These are not regular toothpicks. They're triangular shaped soft wood, and we use them usually for anterior teeth or where you can't get the proxa brush in. and you can gently run that tip along the gingival margin and disrupt the biofilm. And it can even get in 3 or 4 millimeters if the patient is doing it correctly. Some situations, maybe even 6 millimeters, but 3 or 4 millimeters is pretty common. Yes, if you have a deeper spot, you can try to show them how to get into that with this, followed by the water pick, of course. You don't have to use it from lingual. Matter of fact, you shouldn't, just from the facial surface. And you may, as I said, you may have similar products elsewhere. I like the wood rather than plastic. The wood has a little more friction. Plastic may not fully disrupt the biofilm, but but as I said before, you can test this. But if you have a plastic one instead of the stimulant, test it out, see if you're successful at controlling the biofilm. So where it's too tight for the proxa brush, anterior teeth and even posterior teeth, you can use this. It's very easy to train therapists and patients, and this is how you use it. Have the patient hold it like a pencil, not just like a spear, and put it in between the teeth and run it along the side of each of the 2 teeth. What did we just do? We went too far. Let's see if we can get that. That's the forward tooth. Go all the way in and pull it out with it aimed down along the gingival margin. And that's enough to disrupt. And you're compressing the gingiva 2 or 3 millimeters sometimes. And that's why you can get 4 to 6 millimeters in some places. So the side of one tooth, side of the other, keeping the tip aimed down towards the gingiva a little bit. So once again, we'll just look at that. Again, hold it like a pencil, not like a spear. Aim it towards the gingiva. You get more control if you hold it like a pen or pencil. And make sure you can get in and disrupt the side of both teeth in that space. It can be used for the facial surface too, but I think the rubber tip is easier, and but this is okay too. So if you have a big area of recession, you want to get it all the way around the front, you can do the same thing on the facial surface, gently, followed by the water pick. Rubber tips. Now this is another technique, and it can be used for all recession sites not accessible for the toothbrush. Plus the fact, if it's recessed and you don't have any attached gingiva, it's just mucosa, it's very sensitive. So you don't want to brush it either. So you're just using this to run along the gingival margin into the sulcus a little bit. That's another thing. If there's a deep pocket there, then you may actually want to consider grafting in that situation, but usually not. So you just run along the rubber tip, very easy to do. Now, the rubber tip can also be used with baking soda. This is something that I learned from my years teaching at the University of Kentucky. Some people in the hills use rubber tip and baking soda, push it between the teeth and under the gums. And I remember that Tom Rams used it at NIH, National Institutes of Health, and Paul Kais used it at National Institutes of Health. It's a little messy. All they do, take a teaspoon of baking soda, put it on a surface, put a couple drops of water to make a thick paste, pick it up and put it wherever you want it, interproximally, for example. And they can just use it to push between the teeth and actually pump it under the gums. And usually people have used this their whole life. They're usually in pretty good shape. I was surprised to see that. But anyway, but the rubber tip can be used just for the facial surface in recession sites. As I said, pump baking soda around the teeth and also around implants. If you're having trouble with implants, this is where you might want to have try to use the rubber tip with baking soda and push it in between the teeth, followed by the water irrigation high pressure with the sodium hypochlorite. Especially, as I said, as we talked about before, usually the restoration on implants sticks out like a mushroom, and it's not very easy to access between the area where the implant and the gingiva meet. So you have a sulcus there, but it's not easily visible and not accessible. Ideally, it would be nice to have this more open, but then you have the problem of food impaction between implants and teeth and implants and other implants, food implants impaction when you have wide spaces open so they have better access. It really is a problem that isn't fully resolved, but rubber tip with baking soda, pushing it under the gums from facial and lingual or palatal, followed by the irrigation with the water pick, spend 3 or 4 seconds on each side with that warm sodium hypochlorite solution. You can get in there with a small tufted brush to sample the bacteria, but that's pretty hard. Sometimes you don't get a good sample out from under that mushroom-shaped crown. And hopefully when you do implants, you tell your patients that there's more of a chance of food impaction in these spots, because it does often happen, as you've found out if you've been in implantology very long. So baking soda is an antiseptic, harder to use. If you use it in the water pick, make sure you're running fresh water through after you're all done. Tongue scraper, we've talked about that before. Tongue scraper, actually, I like the ones that look like a little rake, plastic rake rather than the brush. So tongue scraper is something else you can use. If you're trying to disrupt the biofilms on the top of the tongue, it reduces the bacterial load overall. And remember, this is a big area for smelly bacteria. So if the patient has bad breath, this is one of the spots. Remember that our mouth, oral bacteria, tongue, gingival, periodontal, these are not the only areas that can be problems. Sometimes, and often even, it comes from the stomach, especially if they have gastric reflux and other such problems. It comes from the stomach. It can come from sinus infections. It doesn't have to be coming from the mouth. It can be coming from pharynx. All these things can be problematic. Now, let's see what else. Toothpaste. Not as critical as once believed, but it does add fluoride. And certainly toothpastes that are desensitizing toothpaste, such as Sensodyne, are quite effective at helping you with your patients who have sensitivity problems. Stay away from high abrasive toothpastes. I personally like toothpaste that have baking soda and other such things, such as Arm & Hammer, other baking sodas. Baking soda, why not have an antiseptic as well as just a cleaning product? The purpose of toothpaste basically was to help you remove pellicle and biofilm from tooth surfaces. It's basically supposed to be somewhat abrasive, but we really don't need it as much. Remember, leaving the pellicle is not a big problem. It's not a problem at all from the point of view of infection. Well, we've ended a little earlier than I thought we would. We were wondering if we'd have enough time for questions, but we certainly will. Important, I want you to know that you can contact Bill Landers at OraTec, and that the number is right here. Or you can contact me on my website. Email me if you have any questions, or Dr. Landers, or Mr. Landers, pardon me, if you want to talk about including anti-infective therapy into your practice. And Bill Landers will arrange for your for all your needs as far as what do you need to start with, how much it will cost. And without any cost, both me and other practitioners will help you with your program. I will be glad to interpret microbial fields with you and answer your questions as you go along. So we intend working with you for the long run if this is of interest with you. And again, is Dr. Rowling there at this time?
I'm here. Do you see me?
Okay. I cannot. I think I have to get out of this to see you.
Oh, yep. You have to get out.
Okay. And
so
show.
stop
There.
sharing. Okay. Now go into your stop.
Okay.
Okay. You need to go into stop sharing, Dr. Page.
Where is that? Right there.
I can do that. I can do that for you.
Oh, end sharing. There we go.
There we go. Okay. We have just a slew of questions here, as you can imagine. Everyone, the course is still on for another 45 minutes. We're going to review questions now, and then we'll have Mr. Bill Landers come on. So please don't log off yet, because the questions are part of your learning. And let me go ahead and bring those up for you, Dr. Page. I'll help monitor those for you. I'm going all the way up to the top here.
Okay.
And there were some good comments that we included too, because I liked the dialogue. It was great.
Thank you.
All right, here we go. And let's go ahead and change our view here. All right. Comment from Dr. Nishimoto: on a broader view, we live in a biofilm on the surface of the planet Earth. Good point. Is there such a thing as good biofilm and bad biofilm?
Yes, we can't live without the biofilms. The problem is, if our immune system allows them to grow further than our body, further than is good for our body, we wind up with disease. That's really the basis of it. Our biofilms in us are in constant balance. And really, whether this balance goes out of balance in our GI tract, you wind up with various GI problems. In our mouth, we wind up with gum disease. We wind up with decay. On the surface of our skin, we wind up with skin problems. Yes, these are all biofilm problems where our body is not doing what it needs to do to control the succession of the biofilms and not let them grow further than they should. And this is also true of environment. If you work in a coal mine, if you have high caustic materials touching the surface of your skin, you're going to get problems. The biofilm will be able to grow more than it otherwise should. That's what our skin is for. It's a barrier function, just like the gingival sulcus is a barrier function to prevent invasion of the bacteria. If you compromise these barriers, we've got problems. So yes, good and bad. And by the way, when we talked about the effect of biofilms on our mental status, we talked about toxoplasmosis. You can imagine if somebody has extreme fear problems, such as they're claustrophobic or they're afraid to go out of the house, agoraphobia. You can imagine these so-called diseases might be helpful for that person. It reduces their fear significantly. So all these products, all these problems really are kind of double-edged. Yes, they're problems, but maybe there are ways this could be useful for some people. So answer your question, they're good, they're bad, and the good ones can be bad. That's the problem. They may not be different biofilms. These are the same biofilms, but under different circumstances. The periodontal biofilm, the marginal biofilm in our gingiva, can be bad if it's allowed to grow too much. It may not be bad otherwise.
How do we distinguish between good biofilm and bad biofilm?
And a simple answer, does it cause problems? Is it causing disease? A simple biofilm, gingival margin, if you're not seeing inflammation, then it hasn't gone to the point where these bacteria have invaded into the sulcus and are causing problems. If they're controlling it up to that point, if that person stops brushing, suddenly that biofilm becomes a problem. If the tissue looks red, it's gingivitis. If it's allowed to get worse, And that depends on your genetics too. Some people it may not allow to get beyond gingivitis, so they'll have minimal destruction. People that are more susceptible to it have a more aggressive biofilm. They're letting the biofilm grow beyond what it should be. That succession has gone too far. Okay.
There is a question. Thank you, Dr. Page. There is a question here about periimplantitis. Is there a blood test to find out why an implant may be failing? So if you have someone that appears to have a quote clean mouth and that implant is.
And implants can fail quickly or long-term, even without infection. One of the problems with implants, they're titanium. And what we depend on is an oxide forming over the titanium when you take it out of the little container and put it in the mouth. And that oxide actually protects. If that oxide, the titanium oxide coat, is damaged in any way, it will, your macrophages will find that spot and react to it, and it will cause a non-infective abscess. It will actually break out little individual micro pieces of titanium with the chemical activity of the macrophage. And this is a problem. So why does the oxide not continue to hold up over the whole implant? I don't know. I don't think anyone knows the answer to that. And it's only the part of the implant that's exposed to that's inside tissue and bone. If you have exposed non-titanium oxide portion of the implant, hemidesmosomes will not attach to that, and you will get macrophage activity in that. There's no blood test that I know of that will tell you that, but you can tell patient may be uncomfortable. It may be exuding exudate. They may taste something. You may see radiographic signs of destruction around that, because there'll be bone destruction around it, especially if it's near the surface, where if this non-infective abscess is near the surface of the implant, where the bone meets the implant, if it erodes up to that spot, you suddenly have a periodontal defect, because bacteria will get down into it. So, wish I could answer your question. Implants aren't perfect. We now have a different technology developing through NIH and others, where they're getting close to the point where they can use organ development by using stem cells. In the future, maybe not in your career, I don't know how old you are, certainly not in my career, but there will be a time when you can take a stem cell from that individual, create a molar, and put it back in, inject it into the proper spot, and a new molar with its associated bone will grow. That isn't yet, but it's coming, hopefully, in the next 30 years or less. That'll be the same time we'll be able to actually grow kidneys and other such organs, which would be great.
A comment here. In dental hygiene school, we were told that a water irrigation unit used to clean between teeth was like spraying a window panel covered in Vaseline with the water hose. In other words, it's not going to take the Vaseline off the window, like how it won't, excuse me, I got kicked off there. How it won't take biofilm off of enamel will just remove large debris. And that was 12 years ago. Is it new science that has proven that it actually works now? I was always taught that you needed a mechanical action to remove biofilms such as floss, not just water.
It's not true. I would say that biofilm is not like Vaseline. You put Vaseline on a glass surface, it's smudgy and hard to remove. A thick biofilm is a thick layer of bacteria. If you just hit it with a water pick, you're going to knock out most of the bacteria in the vertical dimension, and you'll just have a biofilm with a few bacteria left with it. If it's chlorine solution, those will be dead bacteria. So no, I would say that that is not an accurate description of what goes on. And a water pick has been shown. The reason Waterpick Corporation calls their products water flossers is because it's been proven to be more effective than dental floss. And dental floss is less than it should be effective. And it's hard to use. So that's why we talked about not using dental floss. There are other things that are more effective that can be used.
Question here, is Noma also known as cancrum oris?
Yes.
Okay. Comment and a question. There are at least 5 subspecies of FN. Are they all bad?
Yes. As far as we know, we don't know of any spirochete that isn't bad. Remember, these are all related to syphilis. And there was a guy named Rivera about 20 years ago who showed that these were in the brains, spirochetes were in the, oral spirochetes were in the brains of Alzheimer's victims. And is it always in their brains or not? I don't know if the study may not have been big enough to show that. Whether these spirochetes are prime or secondary invaders, we don't know. Are they involved in the active destruction? We don't know. And are there other dementia diseases that these are involvement? We don't know. We do know that their associated cousins, Treponema pallidum, which is syphilis, does cause definitive damage to the brain and will cause dementia, among other things. So we don't want to give these spirochetes the benefit of the doubt. And I don't know how, it's very difficult to grow spirochetes at all. That's why when you send a culture in, it will not come back with spirochetes if they're present. You can't easily grow spirochetes. So doing studies with spirochetes is extremely difficult. So there are no good spirochetes. I'll make that statement.
No good spirochetes. Can the red complex bacteria be present in the oral cavity without causing periodontal disease?
I think so, but I don't know to what extent. And as I said, we'll often take samples from teenagers, and there'll be spirochetes there. They don't have any damage yet, but I assume they will. And if they're allowing spirochetes to grow, they're going to have all the problems associated with spirochetes. Remember, spirochetes are a good example of red complex bacteria, because the other 2 species of red complex bacteria aren't as easy to see in a microscope, but they cohabitate, they co-aggregate with Treponema. So if you have spirochetes, you probably have the other 2 species of red complex bacteria. So yes, they may be present without disease, but maybe if they're just in small amounts or transitory amounts, it may not be a big problem.
This is a couple of questions. So we don't really have a definitive answer on where pathogenic bacteria come from, like from the environment, passing from mother to child, etc. Like we just can't pinpoint how people would get periodontitis pathogens in the oral cavity.
That's not a quite accurate statement. We know it can be vertically transmitted from mother to kids, from father or other people. How many kids kiss babies? I mean, babies are kissable, so we do it. And unfortunately, most of us have some degree of microorganisms that we don't want to transfer, but we do it. These bacteria know how to transfer. They've been around for eons of time, and they're good at what they do. So vertical transfer is certainly one of the ways that is known to transmit these bacteria. Once they're in you, they form microbiofilms elsewhere in your body, so you have a reservoir of them.
This is a comment here from Dr. Nishimoto. The term planktonic means drifter. If you didn't have a home, a job, you are planktonic because you are a drifter in life.
Yes, and the same with bacteria. When they leave a biofilm to go into your body, they're actually invasive. But yes, they're drifting compared to a person doing the same thing. They'll jump on a freight train. Yes.
Here's a question from Rachel. Isn't period diseases or perio diseases are multifactorial? Why are we focused on bacteria only?
If the bacteria aren't there, the disease doesn't go on. The cause of the disease is certainly bacterial. It won't happen if your immune system is strong enough, presumably, but we have no control over your immune system. This is one of the problems with the focus on in periodontal research right now. It's good to know what the inflammatory process is like, But would you rather try changing somebody's inflammatory process, or would you rather just get rid of the bacteria that caused the problem? We know that these bacteria cause gum disease. If you don't have them there, there's not going to be gum disease. So that's a simple issue. Yes, we'd like to have your immune system as good as it can be for general purposes, but if you can control the bacteria, even if you are susceptible, you won't have the disease.
I want to remind folks too that the continuing education course is another 30 minutes. We're reviewing questions right now. So please don't log off if you want credit for today. The question here, can you please repeat how the fecal odor occurs?
Okay. This is called bacterial substitution. There's a common group of bacteria that cause red complex disease here in the US and in Europe. But if you get into places that don't have good sanitation, they don't have good fecal control and so on, and people are contaminated by feces, some of these fecal bacteria may be more capable than an ordinary oral bacteria in that biofilm. So they take over that spot, that eco niche in the biofilm that would ordinarily be taken over by, let's say, P. gingivalis. So instead of P. gingivalis, you have E. coli growing. And that can cause damage too, of course, and it causes more food for the biofilm by invading and causing tissue damage. But it's a different bacteria, and it's what causes the smell in feces. So you will have, in some people, this fecal odor. Most of the people who've been in practice for a period of years have seen that, have smelled that.
From the reception door, sometimes.
Yes.
Right?
Sometimes. Yeah.
You know they're on their way.
Please don't talk at me.
Right. We know you're here. You don't need to check in.
Yes.
What is the role of probiotics in controlling this infectious disease?
We don't know. We know that it works with C. diff infections and with other infections, but as I said before, it may be helpful. We just don't know the answers to this. If you have a lot of the proper oral bacteria, maybe you can replace some of the pathogens. We don't know that, but it's possible. So in the future, that's something to watch. Would it hurt to use probiotics? No, it doesn't hurt, but I would certainly not forego the use of biofilm control techniques.
Question about the toothbrush. Is it a factor in reinfection of biofilm if the toothbrush is not disinfected?
No, probably not. No, remember, you're working it in the same mouth, unless you share a toothbrush with your friends, which I wouldn't suggest. That's like sharing underwear or something. Don't do that. But if you're sharing a toothbrush, if your friend is susceptible, yes, it could be if they're using it fast enough. Remember, most of these bacteria that are more aggressive are somewhat anaerobic. Treponema are not going to survive on the bristle of a toothbrush very long. So you could transmit it if right after you finish brushing, your friend starts brushing with it. But over time, most of the pathogens are gone anyway. I would certainly wash my toothbrush after use. You don't have to disinfect it. Remember, products such as nylon, and the bristles are usually not natural bristles anymore. In artificial bristles, they don't absorb bacteria. Bacteria are on the surface. That's why it's easy to wash off these bristles. If you're taking a sample from one site to a next for your patient edification, and you take a sample from one infected site, you put it on a microscope slide, just wash the brush. And that's good enough. You're not going to have any detectable bacteria after that. And it's the same thing with the toothbrush. You're not going to have detectable bacteria with ordinary care. So I wouldn't worry as much about transmitting from a toothbrush. I do, just from a general idea, don't share toothbrushes with somebody else. Okay.
Or your cat, not advised.
Well, maybe your cat likes somebody else.
Maybe your cat. With sodium chloride irrigation, it also will destroy commensal bacteria. What are we trying to achieve?
It's true, you're destroying more than just the pathogens, but you're getting the biofilm to an earlier state of succession. And if there are not as many of the future bacteria needed for succession around, succession will be slower. That's what you're trying to succeed at. So
Question here. Oh, sorry. Go ahead.
The question is, are you killing any health-related bacteria? Yeah, but not many. And there's plenty of health-related bacteria around if you don't have active disease.
Question here with respect to your message, what is the pathology of calculus?
Calculus is not pathogenic. It's dead bacteria. Dead bacteria are really no problem. The problem is if it's subgingival, you have a rough surface where new biofilms can grow between the chunks or whatever. You notice that calculus is actually one of your body's defenses. When this exudate goes into the sulcus or pocket, it has chemicals to fight bacterial succession, but it also has calcium and phosphate. Your body is trying to calcify the biofilm. It doesn't do it very successfully. It'll calcify a piece here, a piece there, so you get a piece of calculus forming. The dead bacteria, it's been shown that dead bacteria can be compatible with health. When I say that calculus, you have a smooth layer of calculus, you can actually get reattachment over it. That's been shown. So calculus, you're getting rid of it because it's a potential hazard for future biofilms, not just because it's calculus. But yes, you want to get rid of calculus if you can.
Is it safe to use the proxy brush up into the deeper periodontal pockets as illustrated in one of your photos?
I've been using it for over 40 years, so yes. I haven't had anyone die yet, but you never know.
Haven't lost anyone yet from the proxy brush.
No proxy brush deaths.
What are the positive elements of biofilm?
Well, biofilms in our GI tract, for example, some of the bacteria are responsible for absorbing some of the nutritions that we can't personally absorb. Mm-hmm. So they're essential for health, for life, actually. And there's other things that aren't known. As I said before, some of these bacterial biofilms are involved in mental health. So people with schizophrenia and so on, there may be some biological, some bacterial involvement in these diseases. It's just coming to the forefront at this time. We don't know a lot about it at this time, but biofilms are available. Remember, they've been in our bodies since we had bodies, evolutionary times, from the beginning when we were just small creatures. They've grown with us. So we depend on the biofilms as much as they depend on us. So yes, there's good and bad. If they are allowed to go too far in any part of our body, including gingiva, then you have disease.
Question here, if pockets are not the issue, can we stop taking pocket measurements?
I wish. I take them for, they're not very accurate. I take pocket measurements about every third year. I know we're told to do it every time. Well, I think much more important is what's the infection going on there. Pockets, if you're doing a proper maintenance appointment, you're using the ultrasonic probe to go down and you can feel the base of the pocket. If you suddenly have a deep defect, most of the sudden defects are from fractures, by the way, so broken teeth. You can feel it and you can go in and remeasure. So yes, I hate pocket measurement too, but I do it every third year on all my patients, unless I feel like not doing it that day.
What is your opinion on hydrogen peroxide?
Hydrogen peroxide is a good agent for killing too, but it's much less effective than chlorine, and it bubbles all over the tape. You need at least 3%. You use 3% peroxide, and you're going to have you're going to look like you're taking a bubble bath. So it's not as easy to use, not as rapid as chlorine. So basically, I don't use it.
With controlling inflammation at the periodontal level, is there noticeable improvement in the patient's general health?
I don't know. I assume there is. If you're reducing inflammation generally, this is something that depends on the knowledge we have of inflammation up to now. We know high levels of inflammation in our tissue based on measurements that can be taken in blood tests and are taken on a routine basis. If you have a high level of inflammation, there's a higher risk of strokes and heart attacks, among other things. So if you're reducing inflammation in the mouth, as I said, there's a significant amount of surface area in your gingiva. And if it's all inflamed, or most of it's inflamed, you are predisposing to heart disease and stroke. So if you reduce it, yes, you're eliminating it. Is there any tests to show this so far? Any studies to show this so far? No.
There is a question here about water pick. This person was told by the water pick people not to instruct patients to put bleach in the unit because it damages the unit.
Yes, that's crap. Don't believe that. I've had that too. If they run clear water through afterwards, I've had one water pick here that I've used for 5 years at least. And they can break down suddenly. They can break down after 1 year or 5 years. If you use just plain water in it, it'll break down over time. I don't think it's any faster. They're told to do that by somebody in marketing who doesn't want to have a lot of people calling saying, you didn't tell me to use this way. If you tell them the water pick broke, I use chlorine, they said, oh, I told you not to use chlorine, therefore it's your fault, we don't have to replace it. But yes, you can use irrigators are okay. Bill Landers has an irrigator as well. As I said, I don't have any association with Bill formally. I don't get any money from it, but his irrigators are fine, and he'll tell you can use chlorine in.
And we're going to bring him on in a couple of minutes here, so hopefully you all stay on and learn. There are multiple questions. How much bleach, Dr. Page, to water? What is the ratio?
1/2 teaspoon of chlorine bleach in a quart of warm water. That's what Jorgen Slotz used in his studies at USC. You could probably use less. 1/4 teaspoon in a quart would be okay. But I like 1/2 teaspoon. I think that it's probably more effective. But 1/4 would still be effective.
Okay. Any contradictions using that with high pressure irrigation?
No. I suggest highest pressure you can.
Okay. And does high pressure irrigation cause recession? What settings should you put the water pick on?
I always use high pressure. It doesn't cause recession as far as I know. If something hurts, cut it down just because you don't want pain. I should have a bumper sticker like that, but if it hurts, don't do it.
How about, you're talking about common sense here. Do we have to go there here for this class? I mean, some of it, we think about questions about so much in our details, but some of the things is really about listening to our patients too, yes, and what they're telling us. If they have an upset stomach from something, antibiotic, for instance, we have to be listening. Question here, how about sub-antimicrobial doxycycline, 20 milligrams twice a day to inhibit collagenase?
No. You inhibit collagenase by controlling the biofilm. If you use low-dose antibiotics, you will have more antibiotic-resistant bacteria growing, especially if you're using it for over time. And that's been proven. And that's even in the if you look at the graphs that they have in the literature, at least they used to have when they first came to my office with that stuff, they showed it. You can see an increase in antibiotic-resistant organisms. And we known from antibiotic use in general, don't use low-dose antibiotics, don't use topical antibiotics in the mouth at least, because they will, where you have a diffusion going on, a diffusion gradient, you're more likely to have bacteria develop antibiotic resistance in those zones.
And for those of you that aren't aware, you happen to be looking at someone that had an antibiotic resistant infection, and it can happen to anyone. And I was in very good health before I took the clindamycin for a periodontal procedure. So when we're talking about antimicrobial stewardship, it's important to know it can really happen to any of your patients. We don't have a crystal ball. So we have to be certain that that patient needs that antibiotic and looking at the long road. Question down here, and then I'd like to bring Mr. Landers on in just a second. Questions about EMS air polishing with erythritol powder instead of prophy paste. What's your opinion on that, Dr. Page?
Air polishing, I've had a problem with it. I know my friend Tom Rams up at Temple loves using it. I find it very difficult because, and you can use it with baking soda, that's a typical thing, but yes, you can use it with other things too. It can get into the sulcus, it can certainly affect biofilms and so on, but when you're finished, if it's baking soda, you better not step on the floor because the floor is going to be slippery. It gets all over the room. So it's really very easy to get a aerosol of biofilm going around, which means you have an aerosol of microorganisms too, and virus included. So you have this going all over the room. Do you clean your floor off after each time you use it? I don't know. So that's the problem I've had, even with a high-speed suction taped to the air polishing device. I've still had the same problem. So yeah, I like its effect on the biofilm. No, I don't use it because of other problems.
There's a comment here about using bleach in their mouths. This person's in a highly educated, high-income area. Her patients would freak. I'm in Scottsdale, Arizona. My periodontist uses sodium hypochlorite, and it gets pretty affluent on this side of the world too. But I use it because he told me to, and I did see, big changes. So, and that's anecdotal, but I understand it. So I've heard that the water pick 7 is the magic number.
It may be in Las Vegas, I don't know, but I use it all the way up. When you say people will object to using bleach, yes, when you first mention, yeah, you're going to rinse with bleach, and they say, what do you mean rinse with bleach? And I said, no, it's just a dilute solution. It's the same as a swimming pool level of chlorine, and you can even drink it. Doesn't matter. But it's the most effective antiseptic known. It's been tested well on humans. We know it's not going to be a problem. I use it every night. I have for decades, and lost all my hair, as you can see, but that's all.
What about hypochlorous acid oral rinses? What's your opinion?
Don't know. Don't know. No, I don't know.
Okay. We'll have to discuss.
Yes.
There's a question here about allergy, chlorine allergy. If someone has a chlorine allergy, is it a contraindication for them to use the rinse?
I don't know if I've heard of anyone with a chlorine allergy. This is like people saying they have an allergy to iodine. You can't have an iodine allergy because your thyroid wouldn't work if you did.
Right.
You could have an allergy to iodine dyes, which have other products in them. Chlorine it's in your body in large amounts. I don't see how you could have an allergy to chlorine. You may have an allergy. Maybe there's a bleach with a product in it other than chlorine that you could be allergic to, but no, you can't be allergic to sodium hypochlorite directly.
Let's go ahead and take this question, and then we're going to turn it over to Bill here. What about Arestin? What is your opinion?
Never use it. It's another antibiotic. Very, very shaky publication. They had a publication, very well-known periodontists who are seem to be involved financially with the company, and they actually published some a paper originally on Arestin without data. They said they were going to publish the data later. Tom Rams used to say, well, if the data was so good, I think they'd put it on a billboard and not hide it. And I just don't think there's any reason to use topical antibiotics in your mouth.
And topical antibiotics can cause C. difficile as well, even ophthalmic drops after cataract surgery. Minocycline, Arestin. I actually spoke to their medical director about a year ago because that was a question I was getting a lot in the C. difficile course. And what I was told, I mean, if you look at the label for minocycline, there is some chance of C. difficile, any antibiotic. Right. It carries a lower risk than clindamycin, of course, but they said, well, we've never had any reports of it. But if you look at the FDA and so forth, it's definitely minocycline has been associated with C. difficile. So the fact is your patients may not go out if they end up with diarrhea and report to their doctor that I had Arrestin placed unless they're told that in advance. So I'm not sure the tracking of that was copacetic.
Yeah.
Let's see here.
No reason to use it.
If an implant is integrated into the bone, there should be no exposure of the implant to begin with, making scaling area deplaquing no problem. Any comment about that? I'm going to bring Mr. Landers up here in a second.
So there should be no rough surface of the implant exposed, only the polished neck. Well, that's true. In reality, it doesn't always happen that way. Unfortunately, you often have a small amount of the roughened surface of the implant exposed. And ideally, if you're using a high-powered irrigation and preventing biofilm from forming on it, that's okay. It doesn't matter. The problem comes in is accessibility, as we talked about several times before. The crowns on implants are usually smaller than the tooth they're replacing in diameter. So the crown is going to stick out like a mushroom with a flange underneath which it's very difficult to get to the implant. And if you make the crown so it doesn't do that, you have probably an additional risk of food entrapment with the implant. So it becomes a really question of, it probably would be a good idea to try, while you're waiting for the permanent crown, maybe try a better shape of a temporary crown on the implant and see if you can make it less mushroom shape, more flame shape, so that you can get access to the area where the gingiva meets the crown. If that works without too much food impaction, that would be a better option than to have a traditional crown where it's tightly adapted to the gingiva in that area.
Okay, I want to remind everybody that some of these questions that were asked are very detailed questions, and they go way beyond the time that we have available. I would encourage you to reach out to Dr. Page with your questions, and I know he would love to engage you. So let's go ahead and bring up Mr. Landers, and I want to thank you, Dr. Page, for being here today and your time. Dr. Page volunteered this time for us today, and I want everybody to know that. We are really grateful. This material's so important, and it's just really outstanding material that you shared today, Dr. Page. I really appreciate you being here.
Thank you very much.
And do you have any closing remarks for anyone before you go?
I'm on my way to Dunkin' Donuts again. And no, I'm going to sit and listen to Bill Landers.
Okay.
First.
All right. So let me go ahead and bring Bill up, and we're going to change this view here.
Specialize at OraTec just in things perio, primarily diagnostic technology and delivery systems. So there are three products I'd like to talk about today that Dr. Page referenced. One is phase contrast microscopy, another is antimicrobial agents, and the last will be subgingival delivery devices. So talking first about microscopy, the benefits: early pathogen recognition. You can find periodontal pathogens long before you see any changes to the tissues. It, unlike cultural and DNA tests, can detect all 57 known species of oral spirochetes, all of which are considered pathogenic. It can also, unlike any other test, detect inflammatory white blood cells. Those are always present in small numbers in healthy patients, but when you have an inflammation, the white blood cell count goes up dramatically, which you can see on a microscope. And there is no better tool in the world to motivate patients to do their part in the home care. And while the equipment costs several thousands of dollars, the actual cost per test is quite cheap. It works out to be about 25 cents. Lastly, you get your results while the patient is still in the chair in under 2 minutes. But there are some other reasons you should have a phase contrast microscope beyond the periodontal risk assessment part of it. And that is to reestablish your scientific authority and expertise. And the reason I say that is because people aren't going to the dentist for periodontal disease. Compared to the extent of the disease in the population, very few people actually go to the dentist and request to be examined for periodontal disease. So why is that the case? Well, we have to go back to why, or rather how, people learn about periodontal disease. Do they learn about it from their dentist or hygienist? Hopefully so, but that's generally not the case. They learn it from TV advertising, dental product ads. Companies like Colgate spend $100 million a year just on that one brand of Total toothpaste. So you multiply that times all the other companies promoting their dental products, and there's a huge exposure from dental advertising to the population. And what message do they get from all of these ads? Have you ever read the box closely? Here are some of the boxes, and I'll magnify them for you so you can see it better. Anti-gingivitis, detoxifies the gum. Clinically proven healthier gums. On Total's brand, anti-plaque, anti-gingivitis. Whole mouth health. Sensodyne, improves gum health. Listerine, gum therapy, helps reverse signs of early gum disease, redness, bleeding, and inflammation. So who needs a dentist? You can take care of all of your gum problems with products that you can buy OTC. Even worse, the ADA is complicit in that advertising because they grant their seal of approval to products. And so right on the product label, they see that that is accepted by the American Dental Association. So not only does the product say it's going to get rid of your gum problems, the ADA verifies that. So that's why patients don't seek professional help when it comes to periodontal disease. But you can regain that initiative, and the very best way to do that is to get yourself a microscope. First of all, it's a very impressive thing when the patients come in and see you using a microscope. And secondly, when they see their own bacteria from their mouths live on the microscope, that is an extremely powerful persuasion that despite the products they're using and the claims of those products, there's still bad bacteria in their mouths. Moreover, they can monitor along with you during the course of the treatment whether or not the treatment is being effective or not. They can see the proof of the pudding, as it were. So in order to recapture the initiative, you've got to be periodontally proactive in your patients. And that means an aggressive periodontal protocol, testing every patient, every visit, and never let a patient leave your office without knowing whether they have periodontal infection and that this is a communicable disease, that not only it threatens them, but their family, their friends, their significant others. Traditional clinical tests like disclosing solution, radiographs, pocket depths, and bleeding points do not diagnose periodontal disease. They diagnose the sequela of the disease, not the disease itself. So they can't be preventative. They can only tell you when a patient has already suffered damage to the tissue or to the underlying bone. Talking about them in particular, disclosing solutions are supergingival. So it's largely going to be revealing non-pathogenic biofilms because there's going to be primarily aerobic organisms there, which are largely non-pathogenic. It's useful for patient motivation, of course, but totally useless for identifying whether pathogens are present or not. Radiographs are a historic time point. They can identify microbial risk factors. They can only tell you how much bone the patient has lost to disease at that point in time. That's after the fact. It's not preventive. It's not proactive. Furthermore, radiographic bone loss does not correlate with future loss of attachment. So it's not a predictive tool, with one exception, which is an intact lamina dura, which I'll skip over that because it's really not important for this part. So radiographs are not a diagnostic tool. Pocket depths, misconceptions about them. They are also sequela. A 4 millimeter pocket does not indicate disease. You can have 4 millimeter pockets that are filled with nothing but health-associated bacteria, and you can have 2 millimeter sulcus that is heavily infected. Remember, everybody starts off with shallow sulci, so the disease originates in shallow sites. By the time a pocket is measurable, of course, the bone is already lost. Conversely, deep pockets can be risk-free and stable. We talk to dentists all the time that have patients with 6, 7 millimeter and deeper pockets that they're just monitoring over time because the microflora isn't pathogenic in those pockets. It's just the ravages of past disease. It's not currently infected. And the only way to determine that, of course, is by doing a microbiological test. Periodontal probes aren't capable of diagnosing infections. You can't detect an infection with a notched metal stick that dentists have been using for 100 years, long before we even realized that bacteria were involved in the process. If you want to treat infections, you have to use a test that can actually determine whether an infection is present or not. And there are only 3 currently available. One is microscopy, the other is cultures, the third is DNA tests, and I should add the fourth, the Banna test there, but that frankly isn't used very much. Same for bleeding on probing. Since the 1980s, the literature is replete with studies showing that BOP does not correlate with disease progression. Studies, classic one by Boyan here that started the ball rolling in 1988, showed that bleeding on probing at baseline and a 3-month reading had no relation at all to attachment loss 6 and 12 months down the line. And plenty of other studies have corroborated that. Yes, inflamed tissue may bleed, but the question is, are there any confounding factors present? Because lots of other things can cause the tissue to bleed. Probing too hard, for instance, can cause the tissue to bleed. The ideal probing force is 20 grams, and the weight of a periodontal probe is 20 grams. So if you're applying additional force probing mandibular teeth, you're automatically probing too hard. What bleeding on probing is actually detecting is capillary fragility, and that's different than whether or not an infection is present. In fact, there are so many confounding factors that can give false readings for bleeding on probing that there's only a 50-50% chance that when you see a site bleed, that there is actually an infection present. And I think that's best demonstrated by the study by Lang in the Journal of Clinical Periodontology on measuring sites that bled, whether they were actually infected or not. And the false positive ratio, and that's the ratio that the site bleeds, that the site does not bleed but is actually infected, was 29%. So if you're going to treat those sites because they bleed, you're over-treating the patient because there isn't actually an infection present. False negative is even a bigger problem. This is the probability that the site does not bleed but is in fact infected, and that turns out to be an almost 8 out of 10, almost 9 out of 10 ratio of false negatives. So you can't be assured that when you probe a pocket and it does not bleed that it is therefore healthy. That's not the case most of the time, which is a missed diagnostic opportunity, and the patient's going to go on and lose attachment until the next visit when it might show up clinically. So legacy tests don't detect infection. They're a useless historical habit, fraught with both inherent and operator error. And it's time we moved beyond them and started behaving more like scientists and physicians than mechanics. Here's an example of a healthy patient on the left and somebody with a periodontal infection on the right. This is how they manifest microscopically when you use a microscope. That's live on the left. There's very little motion, very little activity compared to literally a sea of spirochetes on the right-hand side, which is typically what you see in advanced infections. But they may not show up clinically. So the things that you can see with a phase contrast microscope are white blood cells, which are the primary inflammatory cell, of course. Treponema, all 57 known pathogenic species show up nicely with microscopy. It can also show one-celled pathogens like trichomonads and amoebae. And it can also diagnose yeast infections with a microscope very nicely. Here's how it's done. If it's for those of you who don't already use microscopy, it's really quite simple. You take a slide, you place a drop of OraPrep on it, add your sample, cover it with a cover glass, and seal it, and you're done. Here it is in a little more detail. It's best to get your samples from the apical third of the pocket. Remember, the deeper you go into the pocket, the more anaerobic it's going to be, and therefore the likelihood of having pathogens is greater. So always try to get your samples from the apical third of pockets. You can pool the samples because from a practical point of view, it doesn't make any difference whether the sample comes from the first molar or second bicuspid or whatever, because if any site in the mouth is infected, there's a likelihood that all of the sites could be infected because these are motile bacteria. They'll colonize every site they can. So you have to treat the whole mouth, if nothing else, to ensure that there are no reservoirs that could infect the primary infection site. Avoid calculus in your samples. That makes it difficult to get a thin specimen. Transfer your sample to a drop of OraPrep. OraPrep is an isotonic medium to curvicular fluid, so it keeps the bacteria happy on the slide. We recommend not disrupting the sample because there's some information to be had by how the bacteria are organized. High organization patterns in the sample indicate a long-standing infection typically. If you do want to track what's happening in individual sites, you can put as many as 3 individual drops of OraPrep and 3 samples on a single slide and monitor them by tooth site over time. Then one applies a cover glass. Best technique is to apply it at a 45-degree angle and then just let it flop down onto the rest of the slide. That traps less air underneath the slide. And then the last step is to invert the sample on a paper towel and compress it. You want to apply a fairly firm pressure, enough that if you are pressing on your fingernail to blanch the fingernail white. The thinner the sample, the sharper the optics are going to be. And then the very last step is to seal the slide. 3 reasons for doing that. One, it stops evaporation at the edge of the cover glass, which pulls a water column along, and you're trying to find what you want to look for in a long river going by you. Second thing, that slide will now stay alive for hours and hours, sometimes days and days, so that's often helpful. And the third reason is some bugs we just can't see looking at a slide fresh. We're not entirely sure why that's the case, but if you just let it rest for about 15 minutes or so, often bugs will crawl out that you just couldn't see at first. We think it might be related to the fact that they're going from a 98-degree mouth to a 70-degree slide and the cold thermal shock, which they get over if you just let them rest for a bit. But anyway, the OraSeal is applied along the 4 edges of the cover glass, sealing it from the outside air. And then you can start your procedures with the patient while you explain what it is you did and what you hope to see or not to see in their samples. And that's all there is to it. It takes longer to explain it than to actually do it. Moving on to antimicrobial agents, this is one that Dr. Page doesn't use. He prefers sodium hypochlorite, as you know, but a lot of patients freak out when you tell them that they're going to be using bleach. So here's an alternative for you. Therasol is a potent antimicrobial agent. Dr. Walter Loesch, before he died, tested it at the Loesch labs at the University of Michigan independently. We had nothing to do with that study. And he found that it killed every bacteria species that he could throw at it on contact. So it is highly bactericidal. It is also highly substantive, which means that it clings to tooth surfaces and isn't washed away by curvicular fluid fast, so it retains its antimicrobial properties over time. In testing at Michigan, it killed aerobes, anaerobes, facultatives, and microaerophilics as well. We aren't FDA approved to make claims that it is a anti-gingivitis or anti-periodontitis product. That's mainly because the cost of the studies is just beyond our means. It typically costs $20 million to do a 6-month clinical study for the FDA. But we do surveys of our users, our clinicians that use the product. And I have a slide here that tells us what they say about the product. So about half of the people use it say they like it because the pockets shrink. 60% say the taste is great. 76 say the patient compliance is much better than with sodium hypochlorite. 80% use it because they never see staining like you do with chlorhexidine in patients. And in approximately the same percentage of people say that they like the effects they see on the tissue. So that's all anecdotal evidence from clinicians using it, but that's really all we have in the way of data. Moving on to irrigation, which is really the single most powerful weapon your patients can use to fight periodontal infections. There is nothing that works as well as sub-G irrigation, especially if you're using an antimicrobial agent. Even using plain water as an agent, studies have shown, and an AAP, American Academy of Periodontology position paper, shows that it reduces gingivitis, depending on the agent you're using, anywhere from 6 to 62%, which can be huge. This is our newest product. It's only been on the market for about 3-4 weeks now. It is the very first home irrigator with a built-in ozone generator. And ozone, as you doubtless know, is a natural antimicrobial agent. It's a very unstable molecule, so it breaks down quite rapidly, which is why you have to generate it on the fly. So what the generator does is it passes an electric current through the water column, and that current dissociates the molecules, and some of them reform as ozone. And somebody mentioned the magic number of 7 with oral irrigation in the questions. That turns out to be the magic number with our Viajet ozone irrigator. At level 7, it produces the maximum amount of ozone. At the lower settings, the ozone concentration can be as low as 0.05 parts per million. But as you move up to setting 7, the ozone production increases to 1.6 parts per million, which is pretty much ideal. It has a built-in electronic display. Also, all of the controls are electronic. There's no mechanical controls on this unit, and they're all built into the handle of the unit. The controls aren't on the unit itself, but conveniently on the handle. There's a button to turn it on and off, buttons to increase or decrease the pressure, and a button to turn on and off the ozone generation. Comes with 3 standard tips and 4 specialty tips with little brushes or tongue cleaning ends on them. It's built-in internal tip storage, a watertight locking reservoir, absolutely no leaks with this design. It has suction feet so that on a wet countertop, it's not going to be tipping over or sliding around. And it is the only irrigator on the market that offers an optional deep pocket irrigation kit. We make an adapter that fits into the handle that allows you to attach subgingival cannula, lure lock fitting on the end. And you can bend these to any shape you want to, and they're typically 24 gauge that we supply. And that will allow patients to access the full depth of even the deepest periodontal pockets. Why is that important? It ensures that you're delivering your anti-infective agent to the very base of the pocket where the worst bacteria live. Ordinary irrigation tips can only push fluids down to about half the pocket depth. So if your patient has a 6 millimeter pocket, they're only going to push things down about 3 millimeters or so, leaving the bacteria down from the 3 to 6 millimeter range untouched. So that's why the cannula are a necessary tool for patients that have deeper pockets. Most clinicians shudder at the thought of patients using cannula themselves at home, but it turns out it's very easy for them to do so. We've been supplying these special tips for 40 years with our various irrigators over the years, and in all of that time, we've never received a single report of a patient injury. And I think the reason for that is they've got the feedback mechanism. Unlike relying on your tactile sense to know when they've reached the base of the pocket, they can actually feel it. And unless they're masochists, they're simply not going to go down to the point where it starts to hurt. You can use this with a lot of different antimicrobial agents. As I said earlier, using just plain water will reduce bacteria levels by about half, which can be enough to get improvement, because the difference between a pathogenic microflora and a health-associated one, even if there are pathogen present, is the number of organisms. It requires a certain density of pathogens before the signaling apparatus turns on their pathogenic genes. So low levels of pathogens typically aren't a problem, and water irrigation may be enough to achieve that. How do you know that? You test the patient on their next visit with your microscope, of course. Obviously, there's a greater benefit when you use antimicrobials in lieu of water. There are a number of agents that are known to be harmful to the machine. And I know Dr. Page says, you know, doesn't have any problem with chlorine, but we do. It's definitely an issue with patients using chlorine. And I think the reason for that is, while he is religious in rinsing the machine out with water afterwards, most patients are not very reliable in doing that. And if they do it haphazardly and that chlorine remains in contact with the plastic surfaces, it does seem to harm the machines. That's also true of essential oils. There's a big craze now for using natural products, but all of the essential oils bind to plastics, and the technical term is craze them, turns them weak and brittle. So we definitely do not recommend irrigation with essential oil products. As a general recommendation, if it comes in a glass bottle, don't use it in a plastic machine. And the only reason a manufacturer is going to supply a product in a glass bottle is because it's incompatible with plastics. Glass is more expensive, it's subject to breakage much more than plastics, so it's a greater expense to the manufacturer. So you can pretty much bet on the fact that if it's in a glass bottle, it's going to be melting plastics over time. We've also found a problem with iodine. Anything in the halogen family seems to be reactive with plastics if it is not flushed out with water on a regular basis. Salts can be used, and in the saturated solution, they can be bactericidal. Dr. Page mentioned add as much to it as the solution will hold, but you want to use the supernatant portion of that. You don't want to get any of those undissolved crystals going through the machine, because that can break them too. And just like chlorine or iodine, if you're using salt solutions, you have to religiously wash it out with plain water afterwards. If those salts crystallize inside the lines, they never redissolve again for some reason, and they just build up and eventually block the tubing. And that pretty much concludes my presentation. And we want to throw it back to Dr. Rowling and see if there are any questions. I'd be happy to answer them.
We have some questions, Bill, and I want to remind everyone that they can tap on the red banner at the top of the screen. It will take them right to your website. And how do they reach you if they need to get a hold of you later? Through the website?
You can't reach me through the website, actually. We'll have to add that feature, I think. But you're certainly welcome to call me. We have an 800 number, 800-368-3529. I'm repeating that, 800-368-3529. And you're welcome to email me as well. My email address is B for Bill, Landers, so it's BLANDERS at OraTec, ORATEC.net.